Hello, everybody out there. This is my first webinar. Kind of weird not being able to see anyone, but I guess there's a bunch of people watching this. So this talk will probably take 30 to 35 minutes. Probably best to do the questions at the end, if that's okay. Just write them down, and we'll definitely have time for questions. So my talk is on the evolution of outpatient joint replacement in the U.S. So my perspective on this is that I've been in practice since 1999, so 21 years. And I would say for the last 7 years, I've seen the total joint replacement that used to be exclusively a hospital-based procedure move into the outpatient arena, where people start to go home the same day. So it's been an interesting ride, and I'll kind of explain at least how I have seen this evolve. This isn't advancing this slide.
There you go.
Okay. All right. So I'm going to go back to my first slide. So this is an outline for the talk that I did. Essentially, we'll start off by talking about the epidemiology of joint replacement in the U.S. today. Also, some projections as to where it's going in the next 10 to 20 years. A brief history of joint replacement in the U.S. Where do we come from? Where are we going? Number 3 is evolution of the outpatient joint replacement, like we talked about, and then future considerations. With regard to hip arthritis and hip pain, the epidemiology, the top 3 causes of people needing hip replacement would be, in this order: osteoarthritis, rheumatoid arthritis, and post-traumatic. Of those 3 groups, about 80% of the patients fit into the first category. So they have osteoarthritis. This is wear and tear arthritis, typically patients over 50, frequently with a positive family history. Rheumatoid arthritis is the most common inflammatory arthritis that still results in people requiring hip replacement. I've seen dramatic improvement over the last 20 years in the management of rheumatoid arthritis from a medical standpoint, so that a lot fewer patients now with rheumatoid arthritis are requiring hip and knees replacement than they did 20 years ago. Post-traumatic, so an injury to the cartilage in the hip, either a dislocation or a fracture, something that leads to premature degeneration of the hip and then leads to a replacement. The final 2 categories would be osteonecrosis or avascular necrosis, where a portion of the bone loses its blood supply. This can also be secondary to trauma, or congenital, where the patient has a congenital deformity. We see this commonly in patients between the ages of 45 and 60. Dysplasia being quite common, where the hip socket does not form fully, and that leads to the need for a replacement, typically before the age of 60. But again, 80% of these patients have osteoarthritis that require hip replacement. For knee replacement, it's the same 3. It's osteoarthritis, again, about 80% to 90%. Rheumatoid arthritis is probably the most common inflammatory arthritis that leads to knee replacement. I list some of the other ones there as well. And post-traumatic. So post-traumatic for knees is particularly relevant to work comp, in that we probably, myself personally, 5 to 10 times a year, will see someone who has an on-the-job injury that leads to a meniscus tear in someone that probably has pre-existing arthritis but was asymptomatic. So what then happens is the meniscus tears. The meniscus is basically a support for the cartilage, and the patient's cartilage wears out. So essentially, the meniscus tear is the, quote, straw that broke the camel's back. So in other words, the meniscus tear led to the cascade of events that led to a premature replacement. So that's particularly relevant, again, for work comp, and does come up. Frequently, the work comp will deny that and say that the arthritis was pre-existing, but if the patient didn't have any symptoms from it, it's usually relatively clear-cut. So prevalence of joint replacement in the US, this is from 2017, so pre-pandemic numbers. 2017, there were over 450,000 total hips in the US. The female to male ratio 1-to-1. In 2017, we did 760,000 total knees in the US. And the female to male ratio has been for quite some time, 2-to-1. So twice as many women as men requiring knee replacement. And that's not just in the US, that's also worldwide. Journal of Rheumatology, April of 19, this is a couple of years ago. They projected joint replacement totals based on current rates of growth for 2020 to 2040. The pandemic came in the spring of 2020, definitely affected the number of joint replacements done in the US. Here in New Hampshire, we didn't operate for a period of about 7 weeks. So it definitely had an impact when you look at the year, over the whole 12 months. Now we're starting to see some rebound from that. So there's a lot of pent up demand for people that weren't comfortable having the surgery earlier. So these are interesting numbers. So projections for total hips in the US, 2020, it was projected in 2019 that there would be almost 500,000 total hips in the US, going up to 650,000 by 2025, 850,000 by 2030. And by 2040, 19 years from now, 1.5 million. Knees, even more. So projected to be a little over 1 million in 2020. I haven't actually seen the numbers, but I'm guessing the number is going to be a little under that, again, because of the pandemic. By 2025, 1.272 million, 1.9 by 2030, and 3.5 million by 2040. As far as hip replacement in the US, first done in the early 1960s. So this is coming up on almost 60 years old. In essence, damaged bone and cartilage from the hip is removed and replaced with prosthetic components. Currently in 2021, typically titanium metallic implants are used. And then the bearing surface, the part that rubs against each other, is most often a ceramic ball and polyethylene or high density plastic liner. Average length of stay for a total hip. When I first went into practice in 1999 and 2000, it was 5 days. We had whittled it down to just under 4 days by 2010. Total knees, these were first done in the US 1968. Damaged bone and cartilage is removed from the end of the femur and the top of the tibia, and metallic implants are cemented to the bone. Typically cement is used. Sometimes cementless applications are used. In most cases, the patella is also resurfaced, so the arthritic cartilage from the patella is removed and an implant is secured to that. So the average length of hospital stay in 2000 was 4 days for a total knee, and by 2010, it was down to 3 days. So by 2010, my Monday total knee patients would go home on Thursday, typically. That would be the average. So several dominoes start to fall over the next few years between 2010 and 2015 that lead to outpatient joint replacement. Probably one of the most important and probably the first thing to happen was blood management. So big change in blood management over the last 21 years for elective hip and knee replacement. When I was in my fellowship in Boston in the late 1990s, we attempted to maintain a post-op hemoglobin of greater than 10, which is a hematocrit greater than 30. Very common for patients back then to receive blood transfusions. Over the years 2000 to 2010, data became available suggesting that a hemoglobin as low as 7 or hematocrit of 21 was actually tolerated pretty well without any adverse events. So the first thing that changed was the transfusion trigger dropped significantly from 10 down to 7. So that eliminated a lot of people that would have otherwise received blood. There was also growing evidence that a drug called tranexamic acid lowers blood loss dramatically. This has become the standard of care in the United States for elective total joints probably over the last 2 years. Tranexamic acid is it's a drug that's been around for probably close to 40 years. It's referred to as an anti-fibrinolytic. So I explain this to patients as when you have a cut or laceration made or incision made with surgery, you immediately start to try to form a blood clot. Your body will try to clot that. We have a feedback mechanism that prevents our entire body from turning into a clot. So As soon as we start to form clot, we have another system that starts to break that clot down. That enzyme is plasminogen. So what tranexamic acid does is it blocks plasminogen for about 6 hours. So when you form a clot, the clot stays rather than gets broken down right away. The end result for the surgeon is, and for the patient is, a dramatic drop in blood loss. So tranexamic acid is given as an IV medicine, typically 20 to 30 minutes before the joint replacement. And we give another dose during the surgery. It's quite inexpensive. I believe it's only $20 or $30 for a dose of this. And it cuts the blood transfusion rate. This is probably underestimates it. This article from 2014 says it decreased the blood transfusion rate by 69%. I think it's essentially almost eliminated blood transfusions for primary total joints. It's almost unheard of. So this was really the first barrier to getting surgeries in a surgery center, because surgery centers don't have blood banks and don't have the ability to give blood. So with the emergence of tranexamic acid, as well as the knowledge that hemoglobin down to 7 was tolerated, post-op blood transfusion issues became eliminated. So prior to tranexamic acid, the average drop in hematocrit for a total joint is 10. Post-tranexamic acid, it's about 5. So if you figure your average female patient comes in with a hematocrit of around 37, they drop down into the low 30s. A male who's going to be in the high 30s will drop down into the mid 30s. So nowhere near a hematocrit of 21 or the need for blood transfusion. So the other downstream effect from this is we basically don't even hardly check labs anymore. So total knees don't need any blood counts or labs done typically post-operatively. Usually we do one measurement for total hips. In the surgery center, we do it as a non-invasive measurement with a finger probe. That's quite reliable. Retransfusion drains were all the rage 20 years ago. These are expensive devices that would actually capture blood from the joint and then retransfuse it into the patient. Again, this was back when we didn't have tranexamic acid. The second domino to fall for outpatient joint replacement was the development of the direct anterior approach for hip replacement. This started to really be learned in the United States around 2008 to 2009. This is as opposed to doing a posterior approach or a lateral approach, which were the typical ways of doing the total hip replacement. I explain this to patients as the surgery itself is the same from the standpoint of the replacement. You're just coming in a different window, so to speak. So the direct anterior incision is actually right under the front pocket for the patient. It's a perfect surgical plane. So if you talk to surgeons, the perfect plane is internervous and intermuscular, which means it goes between muscles. It doesn't go through a muscle, and it goes through muscles that are innervated by different nerves. So it's very unlikely that you would damage the nerve supply to either of the muscles. As a result, it minimizes post-surgical pain, improves function and stability immediately and post-op. It really set the groundwork for same calendar day discharge total joint. That's what that mnemonic is, by the way, SCDD, that keeps popping up. So same calendar day discharge. So that can be done from a hospital or a surgery center, by the way. In the last survey I saw on this from 2019, Journal of Arthroplasty, American Association of Hip and Knee Surgeons, which are all relatively high volume surgeons in the US, 53% were using the direct anterior approach. So when I learned it in 2009, it was about 5% of total joint surgeons were using it. Ironically, in New England in 2009, 2010, there were only 6 surgeons performing the procedure, and 4 of us were in New Hampshire. The final domino to fall for direct anterior was actually the opioid epidemic. Indirectly worked to push patients into the outpatient arena. Just a little background on this. In 2016, opioid overdoses accounted for greater than 42,000 deaths in the US. By 2019, there were greater than 70,000 drug overdoses. Of that group, there was over 60,000 of them were due to opiates. I think the others were methamphetamine and cocaine. So 1.6 million people in the US defined as having an opioid use disorder by 2019. The opioid epidemic in the U.S. From 2016 to 2021 has led to an increased interest in minimizing consumed and prescribed opiates postoperatively, specifically more relevant to total knees, where they would have a lot more pain usually than total hips. Multimodal anesthesia is now the word for using a variety of approaches prior to surgery to maintain pain control after surgery. Traditionally, like 20 years ago, for total knees, and total hips, they would have general anesthesia and then post-op IV narcotics given through a PCA pump for the first 24 hours before even being converted over to oral narcotic pain medicine. So we missed the slide here where we talked about the origin of the opioid epidemic, but suffice it to say, a lot of us that are in healthcare think that it came from the movement in the early 2000s to define pain as the fifth vital sign and pain scales, as well as the very liberal prescribing of opiates that at the time were not, wasn't appreciated what the level of dependence for this would be. And over the next 10 to 15 years, we ended up essentially with an opioid crisis because of all the narcotics that were out there in the community. That's kind of a whole talk unto itself, so we'll move past that. Talk more about multimodal analgesia. So there's a lot of components to this. The first, and actually one of the most important, is patient education. So before the surgery, setting realistic expectations, being really specific about what to expect from the anesthetic, as well as post-op pain, swelling, lack of mobility, as well as going through strategies to manage post-op pain. Preoperatively, we use acetaminophen and frequently COX-2 selective nonsteroidals like Celebrex or meloxicam. These are specific in that they don't affect kidney or GI function to nearly the same extent. Gabapentin, just to show you how much things have changed. When I made this talk in March, we were still giving gabapentin routinely preoperatively, but 2 studies have come out since then indicating that probably not every patient needed to get it. So gabapentin is for nerve pain. I'll frequently use it postoperatively for patients that describe burning pain in the front of the knee, which is maybe 10 to 15% of total knee patients. Noraxial anesthesia. So this refers to anesthesia that doesn't involve general anesthesia. So you're blocking the neural axis at some point to interrupt pain and not give a general anesthetic. Multiple studies have actually shown that for joint replacement, this type of anesthesia leads to lower rates of infection, transfusion, blood clots, cardiac events, and it diminishes length of stay. So Noraxial anesthesia has also become the standard for joint replacement in the US in the last couple of years. In the surgery center, we use short-acting spinals to avoid delays in mobilization, urinary retention, and prolonged sensory blockade. In essence, what we did when we started to do total joints in the surgery center was kind of look at what the complications were, what the potential complications were, and then work backwards to try to eliminate those. So that's what this next slide is about. For outpatient surgery, total joints, the efficiency needs to be precise and predictable to avoid having the spinal wear off too soon. So we basically, as a surgeon, have a 1 hour and 15-minute window to do the surgery without the spinal wearing off. And for the vast majority of cases, that's not a problem. For total knees, regional anesthetic with an adductor canal block is being done now. That's been probably for the last 4 to 5 years. Instead of a femoral nerve block. So for those of you that have had this before or know anything about it, the adductor canal block is an injection in the front of the thigh. It's a sensory block, so it knocks out pain to the front of the knee, but it doesn't affect motor function at all. This is frequently supplemented with an IPAC block as well as a CINHA block. The IPAC does the back of the knee, and the CINHA block is basically a circumferential block around the front of the knee. We're using a drug now called Exparel for these anesthetics. The Exparel is a long-acting local anesthetic that can last up to 72 hours. So we're using that for our blocks. Some places still use ropivacaine, which actually also works pretty well, but may not give quite as long a period of pain improvement. So another option, if Exparel is not available, is to do what's called a periarticular injection, where the surgeon would inject the entire inside of the knee or hip with ropivacaine, which is diluted to provide up to 24 to 48 hours of pain relief after the surgery. Patient selection is probably the single most important factor, though, for a successful same calendar day discharge joint replacement. Who is the patient? What makes them tick? How are they going to deal with pain or anything else that comes up post-operatively? So the ideal patient for this is someone that's relatively young, and relatively young keeps changing. As I get older, young keeps getting older and older. I keep changing it. But in general, for outpatient surgeries, they're mostly people under the age of 75. But this past year, we've opened it up to people from 65 to 75 that are on Medicare, as Medicare is now on board with this. So there's a risk assessment test called the Outpatient Arthroplasty Risk Assessment. Again, like everything that has a mnemonic, it's ORA. It's a relatively complicated way of stratifying patients, looking at 9 different comorbidity areas to predict risk categories. So the lower the number, the more likely the patient is to be able to go home early. We looked at this for the surgical center, and we've had so little issues deciding who to do there, what patients to do at the surgery center. We have just continued with our own protocol, and we don't actually use the ORA at all, really. So in 2018, the American Association of Hip and Knee Surgeons and American Academy of Orthopaedics put out a joint statement on outpatient total joint. This is when it was really starting to take off around the US. They talked about the necessity of appropriate patient selection, patient education and expectation management, good social support. So these are people that have somebody else at home with them. If it's not a significant other, someone that can come in and stay with them and help them for at least 3 to 4 days. The clinical and surgical team has to be experienced and got to be able to do the procedure quickly. The facility and environment have to be adequate for optimizing surgical outcomes. There's also, evidence-based pathways for pain management that we're using now. Blood conservation, we talked about that. Wound management, mobilization, and blood clot prophylaxis. Most of us now for blood clot prophylaxis are using baby aspirin. I only do it for 2 weeks. Some people do it for 4 weeks, but 81 milligrams twice a day for people that have not previously had a blood clot, which is the majority of them, is more than adequate to prevent post-op DVT. So we don't need to use things like Coumadin that requires blood draws or other blood thinners that might cause more wound drainage. So the aspirin is very convenient and generally well tolerated by patients. So this is where we're talking about the complications that we try to avoid. So, in moving surgeries into the outpatient surgery center, urinary retention is a problem if you don't address it. So we do address that, but we do it by avoiding Foley catheters. We pretty much don't use them anymore. We limit IV fluids. So the other side of that is if you're limiting IV fluids, the surgeon cannot allow a lot of blood loss. So there's definitely the onus on the surgeon, especially with hips, to control blood loss. We avoid intrathecal narcotics, which is we don't put narcotics in the spinal. That's another thing that leads to urinary retention. Can also lead to the number 2, which is low blood pressure, hypotension. So we avoid deep sedation. Most of the patients, they have a regional anesthetic. They have a spinal. In the case of a total knee, they have several blocks done with the Exparel. And then in the operating room, they give them propofol. So propofol is a great drug for putting people to sleep. They can put them to sleep so they're asleep, but they're still breathing on their own. There's no opiate in that. And as soon as the propofol is turned off, the patient's awake again, and they don't feel like they got hit by a bus like used to happen with general anesthesia. So avoiding hypotension helps limit blood loss with tranexamic acid. Aggressive surgical management of bleeding. I can't emphasize this enough with hips especially. The bleeding with the total hip will happen early on, so it's on us as surgeons to try to make sure we control bleeding and not get into a situation where we need to give a lot of fluid. Prevention of post-op nausea and vomiting, that's done with IV corticosteroids. These are typically given right before surgery, and they dramatically reduce post-op nausea and vomiting. Same thing with scopolamine patches, which we use frequently. So the final mention there is of IV Decadron, 10 milligrams prior to the incision to decrease nausea and vomiting. It also been shown to reduce length of stay for patients having surgery at the hospital. So I should mention while we're talking about this, all the things we do in the surgery center, we also do in the hospital. The patients are just They're typically older and they may have more medical comorbidities, but we're doing all the same things, basically, regardless of where the surgery is. Post-operatively, managing and preventing complications. Very important to maintain this concept of patient touches, which is you're now doing a relatively big procedure on someone who's potentially going home 5 to 6 hours later. So it's really important that the patient feels that they have the ability to get in touch with us and that we can check on them to see how they're doing. So there's actually been some recent research on this saying that video calls are actually a very good way to do this. Phone calls, we will do typically an early post-op visit, like 3 to 5 days or 5 to 7 days post-operatively with a PA, and then typically 2 to 3 weeks post-operatively with me. A lot of patients now are not doing home physical therapy. They're going right to outpatient therapy about a week later. So it's another cost savings there. These 2 studies that came out in 2019 looking at surgery done in an ambulatory surgery center or in the outpatient department of a hospital. So a patient comes into the hospital and goes home the same day. Comparing that to surgery center, the first study from 2019 had 240 consecutive total hips and knees in a surgery center versus in the outpatient part of the hospital. There was no difference in complication rates or readmission rates. The next study was just total hips, kind of looking at the same question. No difference in 90-day complications, no difference in any other indicator of quality either. This study just came out this past March, Journal of Bone and Joint Surgery. This was one of the lead articles in that journal. So if you're an orthopedic surgeon, that's probably the one journal that is likely to be seen all around the world. This study was a matched pair cohort study that looked at outpatient versus inpatient total joints. So people going home the same day versus people staying. They looked at 30-day adverse events and readmissions. They identified close to 600,000 patients from 2009 to 2018. 3.74% of them underwent outpatient procedures. And as was demonstrated by this study, the outpatient total hips and total knees had a lower complication rate than the ones done in the hospital. Fewer adverse events, no increase in readmission rate. So take this study with a little bit of a grain of salt because it's a small percentage of the cohort that had outpatient surgery. So these were people that were being handpicked that would be good for an outpatient procedure. So especially in the early days, you're getting the healthiest patients of all. So you would expect that they would do better. And this study confirmed that they did. The economics of it, this is relevant to work comp and payers. It's very relevant to patients too. There's a significant benefit, financial benefit to outpatient arthroplasty. So the study from 2014 said there was an average of $7,000 savings per total hip patient, outpatient versus inpatient. The same study from 2014 on total knees said it was almost an $8,500 savings. In general, Journal of Arthroplasty from 2020 states that the overall cost is close to 13% less for a knee and almost 15% less for a hip in the outpatient setting. So our experience at the Bedford Ambulatory Surgery Center, this is one of 2 surgery centers that our practice is involved in and owns part of. The Bedford Ambulatory Surgery Center is owned approximately 60% by physicians and approximately 40% by a hospital. So we started doing unicompartmental joint replacements there of knees in 2013 as an outpatient. In 2014, we started doing anterior hips. So you got to realize by 2014, we had already been doing anterior hips in the hospital for 5 years. And in preparation for the outpatient facility, we had already started sending them home from the hospital within the first 24 hours. So we knew that they could do it. It was just a matter of kind of, perfecting that before we started doing it in the surgery center in 2014. So by 2016, we started doing knee replacements in the Bedford Ambulatory Surgery Center. And again, patients going home the same day. When we first started doing it, we provided the ability for patients to stay overnight. Initially, a lot of people were staying overnight. As we got more comfortable with it, and as the patients got more comfortable with it, more and more patients would go home the same day, which is, I would say now it's almost 95% go home the same day. By 2019, there were 7 surgeons performing total joints at the Bedford Surgical Center. I list our cases there by amount. we were on pace to do about 130 in 2021 there with 3 surgeons. I think looking at how much it's exploded the last couple months with all the Medicare patients now coming there as well, I think we're going to probably be over 250 total joints in 2020, which is almost actually more than twice what we've ever done there in the past. So we definitely see an increase coming. We have more and more patients now asking for this. It's more often that we have to turn someone away because they have a medical problem or a comorbidity. So, and finally, recent removal of total hip and total knee from the Medicare inpatient only list and increasing pressures for cost containment and value have led to surgeons offering same calendar day discharge arthroplasty to select patients with increasing frequency. So the picture kind of shows what we see happening here. There's a wave of patients building, and we think, I personally think over the next 10 years, you're going to see 80 to 85% of total joints in the U.S. being done in ambulatory setting, whether it's as a hospital outpatient procedure or in a freestanding ambulatory surgery center.
Okay. And then your screen sharing, start video. Okay, hopefully we're all set up here. I'm Bryan Bean. I'm Dr. Bean at New Hampshire Orthopedic Center. Thanks for all joining today, and hopefully I'll get to meet some of you in person down the road. I'm going to be talking about ankle injuries, focusing on the diagnosis, the treatment, and the rehab, and trying to hit on some of the more common things that I see, and also some of the more interesting things that I see in my office. So today I'm going to talk about ankle anatomy first, going through the bones, the joints, ligaments, tendons, and nerves to give you a little background. I'll try to hit on that anatomy throughout the course of the presentation to try to make it relevant to the anatomy that you're learning up front. I'm going to talk about ankle injuries, instability, osteochondral defects, cinesmatic injuries, different types of fractures of the ankle, the tibial plafond, and the talus. I'm going to also talk about ankle arthritis and different tendon injuries. I'm going to bring in some unique cases throughout, try to show a lot of examples and some of the interesting cases that I've come across recently. I'm going to make a little adjustment here so I'm centered. Right there. Okay, so this is me without glasses on. I have quite literally been around the whole country. I was born and raised in Portland, Oregon. I went to the University of Washington, studied chemical engineering in Seattle. I spent a year, my first job out of college, working in Hawaii at Pearl Harbor Naval Shipyard as a civilian for the Navy, and then went to a biotech company in San Francisco where I spent 6 years before going to medical school. I had a quarter life crisis, decided to pursue something different, and ended up going to UCLA, David Geffen School of Medicine. The biotech company I worked at in San Francisco introduced me to a lot of really cool medicines, and I wanted to be closer to the patient side, so I ended up going to medical school. Along the way, I had a few kids, and my orthopedic training brought me to Charlotte, North Carolina. My fellowship training last year in Baltimore, Maryland, and most recently to New Hampshire Orthopedic Center in Nashua. I've been part of the group for a little under a year now. I was drawn to foot and ankle because of the variety. So even though you're focused on a very kind of small area of the body, there is a lot of variety. You're working with young patients, older patients, sports injuries, a lot of really interesting trauma and deformity. So here's just a summary of some of the conditions that I'll treat within the foot and ankle world. So now to my presentation, I wanted to go over some of the pertinent anatomy. Here's a look at the ankle joint, and you'll hear terms, the ankle mortise. The mortise is the articulation between the tibia bone and the talus bone and the fibula. So those are the three bones that make up the ankle joint. The talus is a very unique bone. I'll talk about it a lot during this talk. It's made up of 70% cartilage. Part of this bone is some of the hardest bone in the body, but it's very vulnerable. It's got a very tenuous blood supply, and that can be injured. The fibula is very important. It must be out to length. There can't be any changes in the rotation of this bone, or it can have a really detrimental impact to the patient. This is the subtalar joint shown here. This is the posterior facet. It's between the talus and the calcaneus bone. It's made up of three different joints, but the posterior facet is the biggest one and the most important. You'll hear of the transverse tarsal joint, which is between the calcaneocuboid joint and also the talar-navicular joint. The ligaments are very important. These are the lateral ligaments, or the outside of the ankle. The three most important are your ATFL, your CFL, and your PTFL, and these are the ankle sprain ligaments when you hear about ankle sprains. On the inside of the ankle, we have the deltoid ligament complex, which is composed of two components, a superficial and a deep component, and they attach to all the various parts of the outside of the ankle, or the inside of the ankle and the foot. The cinesmatic ligaments are also very important. These are a little bit higher up on the ankle, and they attach the fibula to the tibia bone. You have your AITFL on the front part, and then the backside has the PITFL. You also have your interosseous membrane, which runs between the fibula and the tibia, but that runs all the way up the leg, close to the knee. You have 4 different compartments in the lower leg around the ankle, and all the muscles run in these different compartments. In the anterior compartment, you have your tibialis anterior, your EHL, which is extends your big toe, and then your EDL, which extends your little toes. On the side, you have your perineal muscles, your peroneus longus, your peroneus brevis, and those tendons wrap around the fibula on the outside of the ankle down to the foot. You have your superior peroneal retinaculum, which is a band of tissue that keeps these peroneal tendons from subluxating out of place, and that can get injured with certain ankle injuries. On the backside, you have 2 compartments. One is a deep and one is a more superficial. The more superficial has your Achilles tendon, which attaches to 2 different muscles, your gastroc muscle and your soleus, and those combine to form your Achilles tendon, which attaches to the calcaneus bone on the back of the heel. Deeper to that, you have 3 muscles, your posterior tibial muscle, your flexor hallucis longus, and your flexor digitorum, which allows you to flex your ankle and move your big toes down. Those tendons are part of what is known as the tarsal tunnel components. There's different tendons, nerves, and blood vessels that run in the tarsal tunnel, which goes underneath this flexor retinaculum. There's an acronym or a saying, Tom, Dick, and Nervous Harry, to remember the components of the tarsal tunnel. So this is your posterior tibial tendon is Tom, your FDL is Dick, and nervous is your artery and nerve, and hairy is your flexor hallucis longus. You have nerves that run on the top and outside of the ankle. The superficial peroneal nerve wraps around the side and then the top of the ankle into the foot and branches out in several branches. And then your sural nerve, which runs behind your peroneal tendons and down the side of the foot. All right, so now that we've gone through some anatomy, I'll go back to some of that anatomy throughout the course, but I want to hit up on some of the high yield topics. First, starting with ankle sprains and instability. So ankle sprains are something I see very common. They happen in the workplace quite a bit, and with all various sports injuries and people walking on uneven surfaces and on ice. Most of these occur with inversion type injuries, with the ankle rolling out. And you can get an injury to the ATFL, the CFL, and the PTFL ligaments, starting with the ATFL and then wrapping around to the CFL and PTFL. The majority of ankle sprains, over 90%, are low ankle sprains involving these ligaments, and a smaller percentage occur on the cinesmatic ligaments above the ankle, which I'll touch on later. And those are called high ankle sprains. A lot of different types of associated injuries can occur with these: osteochondral defects, peroneal tendon injuries, injuries to the deltoid ligaments on the inside, fifth metatarsal base fractures, and ankle sprain mimickers like anterior process calcaneus fractures and fractures to the lateral process of the talus. When these patients come in, I always get weight-bearing x-rays. Every once in a while, I'll put a little stress on the ankle to see if there's a cinesmatic injury. Oftentimes, if it's a routine ankle sprain, I will not get an MRI acutely. I'll wait 6 to 8 weeks after injury before ordering an MRI. The reason for that is about 90% or greater of these improve on their own with proper non-operative treatment. Oftentimes we'll see a little chip avulsion fractures, and I treat these just like a standard ankle sprain. The chips come off the bone, and they're usually attached to the ankle ligaments that are torn. I'll let most patients weight bear as tolerated right away using a tall walking boot with or without crutches, and then after a few weeks transition into an ASO supportive ankle brace, which they'll wear for another 1 to 3 weeks, and then start either physical therapy or home exercises. The key is early functional rehab, weight bearing right away, moving the ankle right away to work on strengthening and balance, and also strengthening the perineal muscles on the outside. Chronic ankle instability can occur after patients with multiple ankle sprains or really bad ankle sprains. The patient will come in with a feeling of instability, and they'll often report that their ankle gives out on them, usually to the outside. They may have pain and clicking sensations, which can be signs of injuries to the cartilage or the perineal tendons. And I'll get x-rays, weight-bearing x-rays, and have a very low threshold for ordering an MRI on patients with chronic ankle instability. Instability tests are very important. So there's the anterior drawer, which pulls the talus upwards, and after stabilizing the tibia, and you can see an x-ray view of what that looks like, and inversion Tailor tilt tests where you're moving the ankle in, and both of these just test the competency of your ankle ligaments. For chronic ankle instability, often we'll try a course of non-operative management for at least 4 to 6 weeks with activity modifications, brace wear, and supportive shoes to see if they improve. If they do not improve, then surgical options include what's called a modified Brostrom procedure, where you're peeling, and I'll show you right here, you're peeling the ligaments off the bone and then reattaching them in a tightened position. So you're basically tightening up ligaments that are stretched out from these previous injuries. I'll have a low threshold for doing an ankle scope and putting a camera in the ankle joint to make sure that there's no other injuries to the cartilage. And I'll explore the perineal tendons if needed. You can augment the repair after your Brostrom. There's something called an internal brace, which is made by Arthrex, and it's a synthetic band which goes across the ankle joint to reinforce the repair. That's if you don't trust the patient's ligaments, even in a tightened position. These patients are off their feet for 4 weeks, followed by a boot for 4 weeks, and then an ASO brace. They start physical therapy about 4 weeks after surgery with some range of motion limitations. And the expectation is that they're jogging by 3 months, cutting by 4 months, and then back to sport or back to physical components of their job at about 5 to 6 months. Talking about osteochondral defects. So these are injuries to the cartilage and then the bone underneath the cartilage in the ankle joint. Patients will come in with swelling, pain, and catching and locking sensations within the ankle. And oftentimes they've had some sort of previous, either recent or remote injury. These often happen to the talus much more frequently than the tibia itself, and can happen either on the inside, the medial talar dome, or the lateral outside talar dome. The lateral injuries are usually associated with some sort of trauma like an ankle sprain, and more often symptomatic for the patient. These don't heal very well spontaneously compared to the ones on the inside, the medial talar dome, which are usually not associated with trauma, tend to be larger but less symptomatic for the patient. If I'm suspicious of an osteochondral defect, I'll have a low threshold to get an MRI to look at the cartilage, to look at the bone edema in the talus, and it gives you some clue of whether this is an unstable injury or a stable injury. Sometimes I get a CT scan if the patient has a lot of bone loss, and the CT scan is much more sensitive for looking at bone loss. These can at least be initially attempted non-operative management especially for the very acute ones and ones that are non-displaced or stable. And I'll try to non-weight bear them in a boot or splint for about 4 to 6 weeks, and then try a course of physical therapy. Operative management depends on the size of the lesion. And here's a picture of something that's probably about 1 centimeter in size, maybe a little bit larger. You can do an ankle arthroscopy. You can clean that cartilage lesion up to expose the underlying bed of bone and poke little small holes in it to get the bone to bleed underneath. And what you're trying to do is to try to get a fibrous scar tissue to form on top of the bone to replace the cartilage that's damaged and missing. It's not perfect, but it tends to give patients very good symptomatic relief. And about 85% of these or more are successful. If it's a larger injury, greater than 1 centimeter, oftentimes I'll open it up and not do it arthroscopically, clean it out, and then add some sort of bone graft or cartilage graft to the bed where the cartilage was injured and taken out. There's a few products from Arthrex that I like to use, and I'll show you a picture up here in a second. Rehab for these types of injuries, you'll be off your feet for about 4 to 6 weeks, transition to a boot for 4 weeks, and then a brace for several months after that, with return to sport about 5 to 6 months. Here's some examples. This is of a lateral osteochondral defect, which was treated with an arthroscopic debridement and a microfracture procedure. And this bottom right picture shows one of the cartilage grafts. This is a biocartilage graft from Arthrex that's placed in the bed where the cartilage was before. This is a medial osteochondral defect, larger in size, and this was treated with an open approach. So basically opening up the ankle joint, getting great direct visualization of the defect, and then placing a graft in the defect. Sometimes if it's really hard to reach, larger in size, you'll actually have to cut the bone to get to the lesion. So this is an example of a medial malleolus osteotomy. So you're cutting the medial malleolus bone, flipping it open like a book, and getting direct visualization of the big cartilage defect. You can do all your repair, basically close it back and repair the bone with screws. So that's a useful tool that we can use at times. All right, so moving on to cinesmatic injuries. So as I mentioned before, we talked about low ankle sprains, but these are high ankle sprains involving the cinesmatic ligaments. We have the AITFL on the front and then the PITFL on the back with the interosseous membrane. A small percentage of ankle sprains involve the cinesmatic ligaments or involve complete disruption of the cinesmatic ligaments, only about 0.5% of ankle sprains. However, a higher percentage of ankle fractures will have a cinesmatic injury. These are caused by more external rotation stresses versus the low ankle sprains, which are more inversion stresses. I'll get the same type of x-rays of the ankle, but I will add lower leg x-rays because you can have a bony injury to the fibula higher up in the leg. And I have a much lower threshold for getting an MRI early on for patients that I suspect a cinesmatic injury. You want to look for deltoid injuries, proximal fibula fractures, and also posterior malleolus fractures on the back of the ankle. On exam, they tend to have pain about 5 centimeters above the ankle joint. They can have pain when you squeeze the middle part of the leg. And when you externally rotate the ankle, they often have a lot of pain at the ankle. And those are all clues that they may have a cinesmatic injury. I'll get x-rays, and with the x-rays, you can see widening of the inside of the ankle, which shows a deltoid ligament injury. Sorry, let me go back. And you'll see widening of the space in between the fibula and the tibia. This is your cinesmatic space, and that's a really big clue that you have a bad injury. Here's an example with an ankle fracture. The fibula is broken here, and this is a very obvious one where you see widening of the medial clear space and widening of that cinesmatic clear space, and these all need to be fixed. You may hear the term Mason-New fracture. That's a cinesmatic injury that also has a break to the proximal part of the fibula. And that happens because the injury starts at the ankle, but then travels up the leg through that interosseous membrane, which is often torn, and then the energy travels out through the proximal part of the fibula. So this is a bad injury that often needs to be fixed. In some cases, if you don't have any widening, but you have injury to the ligaments, you can try to treat these without surgery. I'll non-weight bear them for about 2 to 3 weeks or until they're pain-free, and then start physical therapy. You can expect the recovery to be longer than a standard low ankle sprain. It takes about twice as long to recover from these and get back to normal function. Operative, if you're forced to do surgery, can be fixed with either screws across the fibula to the tibia, or they have these what we call suture buttons or internal braces, which is a really heavy suture material with a metal button on the end. And these go all the way across, and they help to stabilize the fibula to the tibia, essentially replacing the ligaments that are already torn. These patients after surgery will be non-weight bearing for about 6 to 12 weeks, depending on the extent of injury. If you place a screw, oftentimes they'll have to be removed. I'll remove them for younger, more athletic patients. Older patients, I may leave them in place. So here's one of the first unique cases that I'm going to show. This is a patient of mine who had a really bad cinesmatic injury from a twisting injury. He's a male of 43 years old. And you can see complete disruption of the deltoid and a huge gap between the fibula and the tibia. Also had a fracture of the fibular shaft, you can see right there. So this was seen by an outside provider and fixed with a combination of a screw going across the syndesmosis. And the provider, because the ankle was so unstable, felt that they needed a pin going across the ankle joint to stabilize the ankle after it happened. So unfortunately, this is not the most compliant patient. He started walking on it and ended up breaking the pin across the ankle joint, which subsequently had to be removed by this outside provider. So this was the second surgery. The patient continued to walk on the ankle against medical advice, and eventually broke through the screw that went across the syndesmosis. And unfortunately, the ankle ended up widening again. You can see widening here and also in the syndesmotic space. This patient ended up in my clinic, and I did a revision procedure. So this is the third procedure for the patient to reduce that ankle again, to reduce the syndesmosis. I did a repair of the deltoid ligament on the inside with suture anchors, and then used a combination of another screw going across the syndesmosis and the internal brace, which is the suture button. And this patient has been doing well now, I think 3 or 4 months out from surgery. Going on to ankle fractures, I'm going to go through different fractures, common and uncommon ones that I see in the ankle area, starting with ankle fractures, which we see a ton of. Ankle fractures can be classified based on the amount of involvement. We have the lateral malleolus on the outside, which is the fibula, medial malleolus, which is our tibia, and the posterior malleolus, which is the back of the tibia, shown here. And you can have ankle fractures with a combination of all of these fractures. You'll hear the terms bimalleolar, which is usually your lateral and medial malleolus, or trimalleolar, which involves all 3 of them. You may hear bimalleolar equivalent, which is a fracture of the fibula, and then a deltoid injury, so a ligament injury, not a bone injury on the inside. And as I talked about before, you can have a syndesmotic injury in addition to all these breaks. You'll hear about the Weber classification, which describes the location of the distal fibula fracture. A Weber A is a break below the syndesmotic ligaments. Weber B is a break at the level of the syndesmotic ligaments. And Weber C is a break above the syndesmotic ligaments. Ankle fractures tend to happen from twisting injuries. They can happen from higher energy axial load, but axial load, high energy injuries tend to create a Pelon fracture, which I'll get into more detail later in my talk. Some of these can be treated without surgery. If you have an isolated lateral malleolus fracture that is not moved, the criteria is less than 3 millimeters of displacement, and is stable on the inside, meaning that there's no ligament injury or anything on the inside of the ankle, then these can be treated oftentimes without surgery. I'll do an external rotation stress exam in the clinic. I did a few of these this week, where you externally rotate the ankle and you look for opening on the inside of the ankle, and you look for this talus bone to move out, laterally, and this fibula bone to move laterally. If it moves, and if I see this inside space open up, then that's unstable injury and will need to be fixed. If it doesn't move, then we can treat them without surgery. The 2 patients I saw this week were treated without surgery because they were stable on this exam. Other reasons to not fix an ankle fracture: if you have an isolated medial malleolus fracture that is not displaced, that can be treated without surgery. A posterior malleolus fracture that involves less than 25% of the joint surface often be treated without surgery. Or sometimes you just have poor surgical candidates and you'll treat them in a splinter cast. The goals of surgery are to restore this ankle mortise. So this is the space outlined here. You want to make sure that this is symmetric. You want to restore the length and rotation of the fibula and restore the synesmosis if there's any widening of the synesmatic space. You want to create a stable ankle and in some cases repair the deltoid ligament. So if you have a deltoid ligament on the inside, this is a bit controversial in the orthopedic literature. Some people are proponents, some people are not proponents. And if you read through all the articles, there's support for either argument. I will fix it in certain cases, but in general, do not fix the deltoid ligament if it's torn. I have a very low threshold for getting a CT scan for ankle fractures, especially if it's a trimalleolar ankle fracture. Here are some examples. I'm just going to go through a lot of different types of ankle fracture patterns, so you can see some of the variety and different ways of treating these ankle fractures. These are all cases that I've done relatively recently. This is a 40-year-old female who fell off a kitchen counter. She had this comminuted fibula fracture, which was treated with a locking plate. This is a pregnant 30-year-old who has a Weber A displaced fibula fracture, which was treated with a combination of a lag screw and a plate. A 40-year-old hockey injury. This is a bimalleolar fracture with a avulsion off the tip of the medial malleolus. I ended up excising that bone fragment on the inside and using a plate on the outside and supporting the synesmosis with a suture button. Here's a bad dislocation in a 70-year-old lady who was walking her dog, and this is a trimalleolar ankle fracture fixed with a combination of plates and screws and synesmatic screws going across. A 50-year-old female that fell downstairs. She had a bad injury to the inside, and I had to support that with several plates and then fix the inside or the outside with a single screw. Another fall on ice involving multiple plates and screws, and then fall downstairs. This is unique. This is one of those posterior malleolus fractures. So this is treated a little bit differently. So you have to approach it from the back side of the ankle, place a plate on the back side of the ankle, and then fix the fibula from either the side or the back side of the ankle. Rehab from ankle fractures. For non-operative ankle fractures, we usually start weight bearing right away within a week or two, or sometimes even right away if it's very stable. I'll put them in a boot for anywhere from 3 to 4 weeks and then a brace after that. Start physical therapy to work on range of motion if needed. But I keep a close eye on them. I get x-rays fairly frequently to make sure that it remains stable. For surgery, surgically fixed ankles, the weight bearing starts anywhere from 4 to 8 weeks, depending on the extent of the injury. And for diabetics, I'll add another couple weeks for their non-weight bearing. After they start weight bearing, they're in a boot for another 4 weeks, followed by an ASO brace, and then a low threshold to start physical therapy. The main thing is you want to work on range of motion and them getting their ankle motion back coming up, so that dorsiflexion motion of the ankle. Now talking about Pelon fractures, also called tibial plafond fractures. So these are the more higher energy, usually higher energy type injuries to the ankle. The mechanism is typically an axial load. So an MVC or a fall from a height, these can all result in these high energy ankle injuries. The lower energy injuries can happen from rotational forces, but these are a little bit less common. Typically see 3 different fragments form in the tibia bone at the level of the ankle joint. And a great percentage of these, 75%, have fibula fractures with them. 20% of them can be open injuries, and up to 10% can actually have injuries on the other side and bilateral Pelon fractures. As you can imagine, the soft tissue injury can be pretty significant, and oftentimes they're too swollen and the soft tissues are too damaged to do surgery right away. So in those cases, you'll put an external frame on the ankle if it's deemed an unstable injury and you're worried about the length of the ankle shortening over the couple weeks that you're letting the soft tissues heal. So you have a low threshold to put in one of these frames on, which you remove once you actually fix the ankle. As far as fixing it, you want to fix the tibia and most often the fibula if it's broken. And for the really bad ones that are just not reconstructible, they're so blown up, you can actually do a fusion instead of fixing it. Here's some examples. This is a male in their 60s who had an MVC, a bad Pelon fracture, and this was fixed with a combination of plates and then a metal rod that went down the fibula to hold it in place. This is a male in his 30s that fell from a height, fixed with a combination of plates and screws. And this is a case I did in my residency, actually, MVC, a guy in his 40s, just a blasted, non-reconstructible tibia that was fixed with a primary fusion. So here's several plates that allow fusion of the tibia to the talus bone. Rehab from Pelon fractures, they're non-weight bearing for 6 to 8 weeks after the injury, depending on the severity. Weight bearing is tolerated in the boot for 4 weeks after, and then physical therapy, again, working on that range of motion and getting that dorsiflexion in the ankle back. Complications are common: infection, wound issues, and you have to counsel the patient on a very high risk of post-traumatic ankle arthritis, which can haunt them early on within a year or two or later on down the road. So now talus fractures. These are can be a very significant injury and have a significant impact to the patient's their quality of life and their pain level. These are broken down by the location in the talus where the bone is broken. We have the talar body, which is where the ankle articulates with the tibia. You have the neck here, which is between the body and the head, and then you have the head, and then the lateral process and the posterior process. The talar body is some of the strongest bone in the body, and if this is broken, it's usually from a very high energy injury, like a fall from a height or a car accident. The talar neck, this area is the most commonly injured. Over 50% of talus fractures happen in this area, and the bone here is relatively weak compared to the body. The head can be a high energy injury. I don't see a lot of head injuries. And the lateral process we see up in the Northeast with snowboarders, and you have to counsel the patient about a high risk of arthritis in the subtalar joint after an injury like this. The posterior process is on the back end, not very common, and rarely do you need to fix those. Tailor neck fractures specifically are typically high energy. They're caused by forced dorsiflexion of the ankle with an axial load. You'll hear about the Hawkins Classification, which is a 4-stage system used to describe tailor neck fractures. You'll commonly get a dislocation as a part of the tailor neck fracture, and that's what the Hawkins Classification outlines. So Hawkins 1 is a tailor neck fracture without dislocation. Hawkins 2 has a dislocation of the subtalar joint. Hawkins 3 has a dislocation of the subtalar joint and ankle joint. And Hawkins 4, which is the worst kind, has a dislocation of all the joints. So the ankle joint, the subtalar joint, and the talonavicular joint. These can be bad actors because the blood supply to the talus is very tenuous and it comes from multiple vessels. So when you disrupt this blood supply, the patient's at high risk for avascular necrosis of this talar body. So avascular necrosis is essentially a dead bone because it loses its blood supply. That can happen in up to 30% of these talar neck fractures. You have a high risk of arthritis, greater than 50% have subtalar arthritis, greater than 33% have ankle arthritis. You can have malunions or non-unions to the bone, wound complications, and infections. Here's an example of avascular necrosis. So this is the talus bone. What happens over time as you lose your blood supply, the bone gets really sclerotic, it starts to fragment, it starts to collapse, and you'll see changes on the x-ray. The bone will get bright white, and on the MRI, it'll get really dark, and this is a really abnormal signal pattern in bone. This is an example of a Tailor Neck fracture I treated in a lady in her 30s from a golf cart injury. This is a relatively minimally displaced Tailor Neck fracture, and I was able to treat this with a combination of a plate and screws. Here's a Tailor body fracture, which is more comminuted, so multiple fragments. Because it's really far back in the talus bone itself, this had to be fixed with a medial malleolar osteotomy. So you cut the medial malleolus, you flip it open like a book, and then you can get good access to this Tailor body and fix it. And then you close the book and fix it with screws. Rehab for talus fractures. These patients are non-weight bearing for about 6 to 10 weeks. You can weight bear in a boot for up to 4 weeks after, and then same story, PT, deep knee bends, get that range of motion back. You really want to focus on subtalar motion, which is that side-to-side movement. So the motion that you need for uneven surfaces. They can get really stiff and have issues with subtalar motion. They usually lose at least 50% of their subtalar motion anyways. You want to preserve as much as you can. Here's a case. This was not a Tailor neck fracture, but a patient that came into my clinic with really bad Tailor avascular necrosis. This is a 59-year-old. She had 1 year of worsening pain, no trauma, no steroid history or other risk factors for avascular necrosis, but did spontaneously develop it. And by the time I saw her in my clinic, I got the MRI. It showed a complete loss of blood supply to the bone, and the bone was, almost completely dead. It had collapsed, it started to fragment, and was extremely painful for the patient. For this patient, we were able to do essentially a talus replacement, which is a relatively new technology. You take a CT scan of the opposite healthy ankle, and you can create a 3D printed metal implant based on the opposite side anatomy. They basically create a 3D image or a 3D replica of the talus bone. You open up the ankle joint, take out all that dead talus bone, and replace it with this metal talus, which is the exact geometry of the talus bone on the other side. And this patient did well. She's about 4 months out from this procedure and doing well. Ankle arthritis is very important. So of all the injuries I talked to you about, they can all result in ankle arthritis, either in the short term or the long term, and it can be a bad actor for the patient. Ankle arthritis is unique to hip and knee arthritis because most of it, the majority of it, is due to previous trauma. If you compare this to hip and knee arthritis, most hip and knee arthritis is only about 12% post-traumatic compared to over 2/3 from ankle arthritis. Only 10% of ankle arthritis is actually primary ankle arthritis. So these can be ankle sprains, instability, talus fractures, ankle fractures, can all result in arthritis. Other causes are rheumatoid arthritis, avascular necrosis, neuropathic conditions and previous infections, gout, and hemophiliac conditions. Patients will come in with severe pain, swelling, loss of motion, and eventually deformity. You can see some x-rays on the side with the ankle starting to collapse. So this is quite a debilitating condition. You can try non-operative management initially with different types of braces, a simple ankle brace or an Arizona brace, which is shown here, which is a leather lace-up brace. Essentially doesn't let you move the ankle at all, and that can provide some symptomatic relief. You can try steroid injections and activity modification to avoid impact activities. Eventually, the patient may cry mercy and want some sort of surgical procedure, and these are broken down into fusion procedures or ankle replacement procedures. This is an example of a diabetic male in their 50s who had an ankle procedure, after an ankle fracture. This was fixed by another provider and eventually went on to failure. It collapsed, and the patient developed severe post-traumatic ankle arthritis and required a fusion procedure. So this is a combination of screws and plates to fuse the ankle together. This is a patient of mine who came in with severe ankle arthritis and also severe arthritis of the subtalar joint below the ankle and the talonavicular joint. She had had several years of debilitating pain, was starting to walk on the side of her foot because of the deformity. And you can see the video of how much of a struggle it is to ambulate. She's walking on the side of her foot. So this was treated with a big fusion procedure by taking down the fibula bone and approaching the ankle from the side. fusing not only the ankle, but the subtalar joint below it and the talonavicular joint. So this is called a pan-talar fusion, where you're fusing all the bones around the talus bone. And then also correcting the deformity. Other options, if you're not going to fuse, are ankle replacements. So these are 4 different systems that I've been trained on through my residency and fellowship, and that I use for different applications for patients that need ankle replacements. There's a few systems that I like from Wright Medical, a newer system up here, which is similar to the Wright Medical system, and the Zimmer system, which is a trabecular metal system. What's unique about this is, unlike the other systems where you approach the ankle from the front part of the ankle, this one you actually break the fibula bone and you can put all the metal implants in from the side and then fix the fibula bone after. This is an example of a patient that came into my clinic. He had a really bad ankle fracture and went on to develop post-traumatic ankle arthritis. He has bone on bone. You can't even really see the ankle joint anymore from this view. He had some of the metal removed by another provider, and then had a lot of scar and bad soft tissues in the front part of the ankle. So he was not a good candidate to do a traditional ankle replacement from the front side. So I did an ankle replacement from the outside using the Zimmer system, which I just showed you. Here's a picture of him limping along with his cane. Here's the ankle replacement after using the Zimmer system. So I cut the fibula bone, placed the metal implants in from the side, and then fixed the fibula bone after. And now finally, talking about tendon injuries, I'm going to go into some detail about Achilles tendon injuries and peroneal tendon injuries, which are some of the more common injuries around the ankle that I see. You can have injuries to all the tendons that I went over in the anatomy section, but I'm going to focus on these 2. Achilles tendon ruptures can be fairly common. The most typical patient is a male in their 30s to 40s. You see the weekend warriors who they're playing flag football or basketball on the weekends, and they'll come in describing a popping sensation or a feeling that someone kicked the back of their leg or shot the back of their leg. Some patients who use steroids or certain types of antibiotics can be a little more susceptible to these injuries, but most of them are just kind of random sporadic injuries. It's caused by a sudden dorsiflexion of the ankle when their foot is plantar flexed, and then you just get that popping sensation. The Achilles tendon is the largest in the body, so when it pops, it makes a loud sound, and the patients really feel it. It tends to tear in about 4 to 6 centimeters proximal to where it inserts on the heel bone. That's because there's a relative area of poor blood supply in this area, and it tends to be the weakest part of the tendon. Patients will come in, you can feel a gap where the tendon is torn. You can do what's called a Thompson squeeze test, where you squeeze the calf, and if that tendon is disrupted, their ankle will not plantar flex down, it will not flex at all. You can also lay them on their tummy, bend their knees, and this middle picture here shows the difference in where the ankle lays. If you lose your tendon, the ankle will sit down flatter, and you can see the difference. Those are the ways to diagnose in the clinic without getting an MRI. I often get an MRI though to confirm the diagnosis and also to see how much tendon is involved. Surgery is a bit controversial. Some people have shown studies that show that non-operative management is actually pretty effective if you treat them in a brace or a cast early on. Some studies, however, show that you have an improved push-off strength, a decreased risk of re-rupture with surgical management. So you'll see varying degrees of how aggressive people are in fixing these. I often have a kind of joint discussion with a patient and give them as much information as I can, and we'll make a decision together. If you're low demand, a little bit older, I'll push them more towards non-operative management. If you're an athlete, have a high demand job, a little bit younger, then I may push the surgical management a little better, because I do believe that there's improvement in push-off strength in certain types of injuries. You can fix these with open or small incision repairs. Non-operative management, here's a boot that we use. This is a Vacoped Achilles range of motion boot, so you can vary the range of motion of the ankle and lock it in place. You have to get to these early, so you have to start this non-operative process within a few days, get their ankle plantar flex down so that tendon will heal in a good position. I'll usually keep them off of it for a few weeks and then start weight bearing, increase the weight bearing gradually over the next 4 weeks. and then start getting that motion back, starting in a plantar flex position and trying to get them to neutral after about 6 weeks. I don't like them dorsiflexing the ankle past neutral for about 12 weeks after this injury, trying to get it to scar down in a really tightened position. When you do surgery, like I mentioned, athletes, high demand jobs, people that come in a delayed manner, sometimes they'll come in your clinic 1 or 2 weeks later and they haven't been treated appropriately, and they may be someone that I would prefer to fix. And some people just come in and they really want it fixed. They've done their own research and they want it fixed. Open technique is what I prefer, a larger incision along the edge of the tendon. Opponents to this will say that there's higher wound complications and higher risk of infection, which is true, but I think you get a really good look and good repair by doing an open technique. There are percutaneous techniques with smaller incision. Arthrex has a nice product. I've had some exposure to this, but tend to favor the open techniques. You can get nerve injuries with this, but theoretically a lower risk of wound issues. Here's a patient that I saw in my clinic. This is a 55-year-old male, very physical job. This was not a work injury, happened at home, but he elected for an open repair after discussion with him in the clinic. 3 weeks later, he fell after his repair and ended up re-rupturing through the same tendon. I had to take him back to the operating room and I did a revision. So I had to remove some of the damaged tendon, which ended up shortening this tendon by a few centimeters. I re-repaired it, and to get the length back, had to do this is called a VY lengthening, where you go higher up in the Achilles, you lengthen this fascia here, and this can allow you to lengthen the tendon by several centimeters. And he's done pretty well after this repair. And finally, talking about peroneal tendon injuries, these can happen to the peroneus longus or peroneus brevis tendons. These are the tendons that wrap around the outside of the ankle behind the fibula. You have your superior peroneal retinaculum, which I mentioned before, keeps these tendons from subluxating out and becoming dislocated. Often this happens in athletic injuries or from chronic overuse injuries. They can be confused from ankle sprains and can be undiagnosed. 4% of ankle injuries actually have injuries to the peroneal tendons. There's a whole spectrum of injury from tenosynovitis, which is inflammation of the tendon, a tendon tear, tendon instability, or tendinopathy, which is more of a chronic degeneration of the tendons. They tend to be injured by a forced dorsiflexion on an inverted foot. You often see longitudinal tears of the peroneus brevis. That's the most common tear that you see. And patients with a cavus foot, so people that walk on the side of their foot or have unstable ankles, are a little more susceptible to these types of injuries. On exam, they'll have posterior lateral pain in a different location than a typical ankle sprain. They have issues with eversion of the ankle, which is the primary function of the peroneal tendons. You may see instability of the tendons when you circumduct or have them move their ankle in a circle, and their ankle may just feel unstable. I have a low threshold for an MRI if I suspect a peroneal tendon injury. You can try non-operative management if you're suspicious of a small tear, a brief period of non-weight bearing followed by activity modifications, a boot, and physical therapy. For those tendons that need to be fixed, there's different options. You can resect part of the tendon if it involves less than 50% of the tendon, or you can repair it with suture. You can do a tenodesis, so you can actually take out a section of the tendon that's really damaged, and then you can tie into the other. You have two peroneal tendons, so if one is good, one is bad, you can take out part of the bad tendon and tie the tendons together above and below the area that was injured. You can do a tendon allograft, where you take out the bad tendon altogether and replace it with a cadaver tendon. And then you can do other types of procedures to stabilize the ankle ligaments or to cut the bone if they have, if they walk on the side of their foot and if they have a cavus alignment. If the tendons are unstable and this SPR is injured, then you may have to repair that ligament also, and sometimes deepen the fibula bone itself so the tendons do not dislocate. And those are all ways to augment the procedure. For rehab after repair, they're usually off their feet for several weeks, followed by a boot for 4 weeks. It's important to start early physical therapy. The peroneal tendons can be very finicky. They can scar down and tighten up and be painful down the road. So I like passive motion very early on in the recovery phase. And if you do a repair of the SPR or a tendon allograft, they'll tend to be off their feet for a longer period of time. Here's a case. This is a work injury on a 53-year-old male. He was stepping out of a loader. This was in 2019, and rolled his ankle. He tore the peroneus longus tendon and was seen by an outside provider who underwent a debridement of the tendon and did a tenodesis to the healthy peroneus brevis tendon. Unfortunately, he had persistent pain after this procedure, and he started walking on the side of his foot, and he had an unstable ankle. I saw him in my clinic. He had an MRI, which showed a real thick, painful tendon on the outside. So this is his remaining tendon. So he started getting this tendinopathy, which is the more that chronic degeneration and thickening of the tendon. This was treated. The remaining tendon was deemed to be non-salvageable. So I ended up fixing this by taking out the tendon and reconstructing it with a cadaver tendon. So this is an allograft cadaver tendon, which was plugged into the healthy tendon up above and then plugged into the bone down below. He was walking on the side of his foot, so I cut the heel bone, secured it with some screws, and then did a brostrum ligament reconstruction for the unstable ankle. All right, so that's it. A whirlwind of information, but hopefully this will be a good reference for you guys and give you a little exposure to a lot of the common injuries that I see in my clinic. And a lot of these are work-related. As a reference, this is orthobullets.com. It's a good, if you haven't heard of this website, it's good to check out. A lot of bullet point information. You can just type in the type of injury or the topic related to any orthopedic topic, and it'll give you some good bulleted information. It's a good resource, and I got some of the content of my presentation from OrthoBullets.
All right, so I'll go ahead and get underway since that took a few minutes. I apologize for that, but thank you for having me as a presenter. So as Maureen introduced, I am a pharmacist at Performix Specialty Pharmacy, and we specialize in compounded therapies. One of the specialties that we really see the most of or dispense the most of is our compounded topical pain creams and therapies. So I guess along with that type of therapy, we get a lot of inquiries about CBD. So I'm here to talk a little bit more about cannabidiol or CBD and just dispel some myths and help you guys understand really how it works and what role it has in a patient's therapy. So by the end of the presentation, I hope to be able to allow you to understand, the current marketing status of CBD in the United States, understand what is called our endocannabinoid system, which is where CBD or cannabidiol has a role, and comprehend the pharmacology of CBD, its place in therapy, its efficacy, meaning how well it works, and adverse effects that patients could potentially experience from using the therapy. I hope that you gain a level of comfort with discussing or identifying various dosage forms, their availability, and different strategies with patients dosing. And in the end, hopefully you'll be able to identify or evaluate different considerations in product selection, such as THC content, purity, and quality. There are a lot of different CBD formulations, so hopefully I'll be able to dispel some differences between the different formulations, allow you to identify some key concerns associated with CBD supplements or products, I should say, and then, be able to evaluate some common scenarios where patients may be expressing interest in CBD and various CBD therapies so that you can anticipate and address common barriers to the treatment and, be able to advocate or advise patients, what possible steps they have. So in terms of CBD, also known as cannabidiol, it's been really gaining some traction and popularity in the nutritional industry. We see different shops kind of opening up or popping up all over the place, and there's a lot of misinformation out there, but regardless, it's gaining a lot of popularity. In 2018, there were about a little over 235 million in sales, which was up 57% from 2017. And then it's projected to be upwards of a $20 billion industry come 2024. So we'll talk a little bit more about CBD and how it's available and, how it can be used. So in terms of the current market, I'll go into some definitions in a couple of slides here, but marijuana and hemp are common terms that are used pretty much interchangeably. There is a slight difference. So marijuana-derived CBD is considered illegal federally. Hemp-derived CBD is legal. So the CBD supplements are products that you see out on the shelves and, gaining popularity that's available over the counter and just some general stores is legal. But, the FDA has some restrictions. So the FDA has approved one specific CBD product, and therefore that one CBD product is trademarked and patented and cannot be distributed or sold or replicated. There are a lot of local and state laws that play a role in interstate commerce. We won't really get into that into great detail, but from state to state, there are varying or differing legal restrictions. Federal law actually prohibits the marketing of CBD products as dietary supplements in the nutritional industry. So it's just considered an over-the-counter product, not necessarily an actual supplement with any type of nutritional value. So the use of hemp goes back tens of thousands of years. It's been around in existence for a long time because it is derived from a plant and has developed a lot of different medicinal and other uses. Back in December of 2018 is really when the U.S. Farm Bill was passed. It became law, and that's what freed up a lot of the ability to create formulations and sell formulations that were derived from hemp. So that's when it was officially legalized, and the limitation or the caveat is that any CBD product that is considered legal must contain less than 0.3% THC. This Farm Bill legalized the cultivation and interstate shipment of hemp that is farmed, so long as it meets that criteria of containing less than 0.3% THC. So let's get into some definitions. Cannabidiol, or CBD, is an abundant what's called a phytocannabinoid. CBD itself does not produce any high or any kind of psychoactive, it doesn't have any psychoactive activity, and it's derived primarily from the hemp plant. Cannabinoids are naturally occurring. They're chemical substances found in either plants or in our bodies. So phytocannabinoids are found in plants, such as the cannabis plant. There are actually upwards of like 100 different cannabinoids found in the cannabis plant, and more are being identified over time. Another type of cannabinoid is called an endocannabinoid, meaning it's something that our body naturally produces. And this is what is part of the major function of what's considered our endocannabinoid system. So a cannabinoid that works within our own body and is naturally produced by our body. So cannabis really refers to a specific family of plants called, I'm sorry, I have a hard time pronouncing this, cannabici, I believe. There are a couple of different strains. So when we hear different terminology kind of thrown out there, hemp is really a strain from this family, typically referring to Cannabis indica. And this particular strain contains roughly less than 0.3% THC. So it has very low THC content and relatively higher CBD content. This is considered more of a non-intoxicating form of CBD. Marijuana, on the other hand, is a strain of the same family plant, but it typically refers to a different strain, Cannabis sativa. So this typically contains a higher degree of THC, which produces that euphoric feeling or high when consumed or smoked or otherwise used. So there are differences between, recreational and medicinal and synthetic cannabis. Cannabis is just a general or broad term for this CBD containing product. And then hemp specifically is less than 0.3% THC, marijuana specifically over 0.3% THC. And then we have the synthetic cannabidiol, which is made in a lab, and that particular cannabidiol is available as an FDA-approved drug that's actually used to treat epilepsy. So the endocannabinoid system, I will refer to as ECS, is a system within our body that's naturally occurring, and it's a communication system. And the way that I really think of it is that it maintains homeostasis, that overall balance within our body. The endocannabinoid system is really made up of the endocannabinoids, their pathways where they communicate, and their receptors, along with enzymes. So enzymes are substances that are produced in the body, and they regulate different metabolic processes and chemical reactions to control levels of chemical communicators in the body. Tetrahydrocannabinol is THC, and that's an abundant phytocannabinoid that is commonly referred to and found in marijuana. This is the psychoactive type of cannabinoid. So the endocannabinoid system is found in all different areas of the body, including the brain, our eyes, our skin, our immune system, our joints, stomach. So this is really why a lot of the CBD products have a plethora of indications. I shouldn't necessarily say indications, but uses or benefits when taken. So the endocannabinoid system is regulated by a lot of different things in the body. So there are certain systems, there are certain things that will upregulate our endocannabinoid system and increase the production of those endocannabinoids. And there are other things that suppress our endocannabinoid system. So things such as inflammation, our metabolic imbalance, pain, cancer, a lot of different disease states will upregulate our endocannabinoid system. And keep in mind that ECS is what really maintains homeostasis. So during these pathophysiological states, our ECS is upregulated in response to those conditions to normalize bodily functions and hopefully protect the body, inhibit disease progression, and minimize the signs and symptoms of that disease state. So the ECS is comprised of three different components. Endocannabinoids, there are two major endocannabinoids. Cannabinoid receptors, which those two endocannabinoids really bind to. There are two main cannabinoid receptors. Each one is found predominantly in different areas. So the CB1 receptor is mainly in the central nervous system, in glands and organs. The CB2 receptors are primarily involved in the immune system. And then we have enzymes. So enzymes help to regulate the production and breakdown and activity of those endocannabinoids on the receptors. So there are two endocannabinoids. I'm sorry, this didn't quite come through. The endocannabinoid receptors, CB1, primarily in the central nervous system. I'm going to kind of skip past this real quick. We'll be able to discuss this in a little bit more detail further down the road. So the ECS stressors, our endocannabinoid system, I mentioned that it maintains homeostasis. So different things that can impair or strain our endocannabinoid system can lead to different pathophysiological conditions like skin conditions, depression, different chronic illness, obesity, fibromyalgia, chronic pain, and many, many more. But these same conditions can also put strain on the ECS. So it's kind of twofold. Things that put strain on the ECS may also result from an overly strained ECS. So there are different things that are considered toxins or toxic to our endocannabinoid system. They primarily include pesticides, phthalates, and insecticides. So a lot of environmental kind of factors. And these toxins can alter the function of the healthy function of our endocannabinoid system and receptors. And the cannabinoids really exhibit a protective effect against these toxins as well. So our ECS is really twofold, that it can be impacted by toxins, but also protect our body against those toxin exposures. So alcohol is a major factor with the endocannabinoid system function. The endocannabinoid system, with chronic alcohol consumption, it can really downregulate our ECS, and the long-term alcohol abuse can deplete our body of those endocannabinoids and downregulate that ECS and make it less effective, which can really impair our overall homeostasis. General stress, of course, we always talk about like ways to manage stress. The endocannabinoid system is involved in that fight or flight phenomenon. The endocannabinoid system helps our body to manage and properly respond to different stresses and anxiety, but also excess stress and anxiety can deplete our endocannabinoid system. So different things that we can do to support our endocannabinoid system. These are non-cannabis related, but they include stuff like herbs, spices, teas, exercise, healthy weight, stress management, moderation of our alcohol consumption, and just, healthy things that we normally hear kind of discussed over time. Healthy fatty acids, our omega-3 and omega-6 fatty acids, our fish oils, all of those things help to maintain a healthy endocannabinoid system. So I mentioned endocannabinoids. We have two that our body primarily produces on its own, but phytocannabinoids are found from plants, and phytocannabinoids, when consumed, can act on our endocannabinoid system similar to our endogenous or natural endocannabinoids that we normally produce on a daily basis. So phytocannabinoids are derived from plants. THC specifically is from that marijuana plant, the sativa strain. That's the main source, but the cannabis family of plants contains well over 100 phytocannabinoids, and they're still identifying more. CBD is another cannabinoid found in the plant. So this is a phytocannabinoid derived from a plant source. And when consumed or inhaled or used in some form or fashion, can influence our CB1 and CB2 receptors and increase our own natural endocannabinoids as well. So CBD has a lot of activity in various areas of our body. We originally mentioned at the beginning of the presentation that our endocannabinoid system is in our brain, our immune system, our organs, all of that. So the receptors that these endocannabinoids and CBD work on can target serotonin. They can work on serotonin receptors. I won't get into the fancy terms here for like the initials and numbers, but the TRPV1 receptors have a lot to do with inflammation, epilepsy, and pain relieving benefits. There are other receptors that help with blood pressure, have a role in cancer cell proliferation, which is really the division of those cancer cells and replication of them. And then there are others like PPARs. That's a fancy term for a long word that I couldn't pronounce, but this has really pain relieving analgesic benefits. It offers some protection of our nerves and has a role in our cardiovascular system as well. CBD also binds to opioid receptors in our body. So the CBD binds to our mu and delta opioid receptors, and these really work better and may reduce the need for opioid painkillers. So when we do use CBD and CBD is binding to those opioid receptors, very similar to the opioid drugs such as oxycodone, you know, the CBD can have an impact on how effective that opioid drug is and may, in fact, mimic some of its activity in providing pain relieving benefits, and may decrease the need potentially for how high of a dose of that opioid is needed. CBD also has a role with dopamine as an antipsychotic, so it can help to kind of normalize those chemical transmitters or neurotransmitters in our body to maintain a healthy, you know, mental health type of state. So these are the different receptors in the body and kind of what CBD does. It will either bind to a receptor and enhance that activity, or it'll block a receptor. And depending on whether it's enhancing or blocking, that's how it lends its benefits. So for example, there are serotonin receptors, and they bind and mimic serotonin in our body to provide some pain relief and anxiety benefits. CBD from a plant can bind our own body's natural CBD2 receptors and help to decrease inflammation. So this just kind of summarizes, you know, where the CBD from the plant binds, what type of activity and potential effect it can have. As you can see, it has a lot of involvement with inflammation and pain relief. So these are just a couple of different examples of cannabinoids, and they're that are found in plants. These are the more common ones. The supplements are I shouldn't say supplements. The products that are available for purchase over the counter really have gained popularity as the CBD component of those plant extracts has really gained popularity. But these others are also gaining popularity because each specific cannabidiol or CBD type component or cannabinoid will play more heavily in certain areas of our body than others. Like some are more relevant or involved with sleep regulation or anxiety or pain. So there's a lot of studying going on with each of these each type of cannabinoid to see what specific role or benefit they can really have. The top 4 applications for CBD are pain, anxiety, depression, and sleep. This is what I really get asked about the most. There are some, you know, special considerations to take when considering treatment options with CBD, or, you know, when a patient considers CBD as a maybe adjunct to their other therapies. CBD can actually enhance our body's insulin sensitivity and increase the effectiveness of insulin. So these are things that are on maybe my mind as a pharmacist or a prescriber's mind when making recommendations for patients if they're considering CBD. CBD can have possible drug interactions with seizure medications, and CBD could inhibit different liver enzymes And liver enzymes are involved in the breakdown of commonly used medications. So things like NSAIDs, non-steroidal anti-inflammatory drugs, opiates, statins, blood thinners, all of those can be impacted by liver enzymes. So there is definitely special consideration in recommending CBD to patients who are currently using these medications. The primary study for identifying drug interactions was with the product Epidiolex, which is the synthetic cannabidiol. And the reason why we have this data is because it was studied for its effects in treating epilepsy. So there are a lot of different dosage forms for CBD. They're available in capsules, they're infused into drinks, they're available in suppositories, they're available in gummies or chews, they're available in pet products, topical formulations like creams or rubs, capsules, and what I see the most of are liquids, sublinguals, drops, that sort of thing, where it's a concentrated liquid put like under the tongue or in the cheek to absorb through the oral mucosa or be swallowed. But there are a lot of different products out there, and we'll go into what could distinguish choosing one over the other. So bioavailability is really the term that indicates how, when we consume a medication or apply something to our skin, how much of that is consumed or applied, how much of that gets absorbed into the bloodstream. So in terms of CBD, we have to think of fatty compounds and like dissolved like. So CBD is a plant extract and structurally is very similar to fat. So if we consume an oral capsule or some type of edible containing CBD, consuming it with food or supplement that contains other fat-like substances will improve its absorption. When we consume something by mouth, it's important to understand first-pass metabolism. So what first-pass metabolism is you consume something and it goes down into your stomach, and then it goes past the stomach into the GI tract. And from the GI tract, your blood flow picks up that medication, that CBD, the nutrients in our food, and it goes through, it first goes to the liver, and from the liver, it gets broken down partially, it gets processed by the liver, and then it goes into circulation through our bloodstream. So there are the oral formulations that are consumed, like capsules or edibles. The drug goes through some pretty extensive first-pass metabolism. So by the time it reaches the bloodstream, it's largely broken down into something that's less active. So, you know, there are other dosage forms like nasal sprays or vaporized forms, and that can bypass first-pass metabolism and enhance how well that consumed form of CBD is. So we commonly hear a term called broad spectrum versus an isolate. So broad spectrum is pretty much any CBD product that's out on the market without a prescription. So there's one prescription, Cannabidiol, Epidiolex, which is a patented product, contains one cannabidiol, and it's synthetic. There's no THC, but there's also no like whole plant benefit to taking it. It's the one isolated phytocannabinoid, as opposed to the other CBD products that are out on the market, which are considered full or broad spectrum. They have what's called like a hemptourage effect. So you don't get that one isolated form of a phytocannabinoid. You get all different phytocannabinoids, upwards of 100, but you also get things such as terpenes, fatty acids, plant sterols, vitamin E found in the plant, and that really lends itself to improved bioavailability, meaning more of that medication or more of that supplement or more of that product or CBD is going to end up in the bloodstream to be beneficial or act on our ECS. So one of the major concerns with CBD products is quality and control. So some things to really keep in mind are to identify, which isn't always easy, but speaking with a healthcare professional or some other trusted professional can help patients, guide them into choosing or selecting a higher quality product. A clean source is really important. So cannabis or hemp is cultivated, it's grown, very much farm-like, and it's not very highly regulated. So a lot of these, the conditions of cultivating the cannabis plant is really critical in terms of the quality of the final product. So with increasing popularity of CBD, that's led to a lot of compromised and tainted sources. So independent lab tests of about the top 240 selling products, of those, 45% claiming to be THC free actually contain THC. About 70% found to be contaminated with heavy metals and other toxins. So keep in mind, earlier in the presentation, I mentioned that toxins can really, impact how our ECS functions. So our body can protect us against toxins through that ECS, but also toxins can negatively impact the ECS. More than 50% were inaccurately represented in terms of the concentration of CBD. So some products, some of these top 240 products had no CBD at all, while others had 6 times the claimed amount. So it's really important to know the source. So in terms of accuracy, this is kind of another study identifying 84 different products that were evaluated, and about 43% were underlabeled, meaning the actual content was greater than 10% more than what the label claimed. Others were overlabeled, meaning it claimed to have more than it actually did. And then only about 30% of those 84 products were accurate, tested to contain about within 10% of the labeled CBD content. So there's a large range here in terms of accuracy and dependability, which is why the quality and control of these products is really highly scrutinized. And it makes it very, very hard for clinicians and for patients to make recommendations because of this. So ensuring the product quality. These are key things that really should be reviewed or looked at when to identify a high quality product. It's good if the company who is producing the product has a third-party lab test their product, if they can claim that it's solvent-free. CO2 extraction techniques tend to be the cleanest and the most reliable. Also, THC content must be less than that 0.3% and match the label. So what we see in the pharmacy world is what's called a certificate of analysis. The certificate of analysis is a third-party test that identifies the purity of the product and would indicate if that CBD product had greater than 3.3% THC. It would actually specify what the concentration is, but it would allow us to identify if it contains more than 0.3% THC. So it would also be important for those cultivators who are farming these plants to use non-GMO seeds and have a strain that is considered, or the product should be considered broad spectrum. So they're not extracting or chemically processing the plant to narrow down that CBD down to a few isolates. It's really most beneficial for the extraction technique to get rid of the more plant parts and the impurities and keep all of those terpenes and vitamins and nutrients and fatty substances and all the phytocannabinoids found in the plant. So there are different things that in regards to product labeling that also make it very confusing. There's absolutely no standardization. So like when you go and purchase an over-the-counter supplement or Over-the-counter medication, there is very specific and standardized labeling so that you know what to expect, how to use a product. There is none of that when it comes to CBD products. So on the label, it's good to look for a statement of identity, identify the net weight in both US and metric measurements. It should have a facts label, it should have a list of ingredients, and it should have a name and place of business. So for product labeling, it can become very confusing. A lot of the products will claim the total container CBD content, which can be very misleading because people will often confuse that total container CBD content as the content per dose, because traditionally speaking, when we look at supplements and medications and common over-the-counter type products, the claim is for the amount per dose or per unit, like per tablet, per capsule. But CBD is not that way in most cases. Most of the time, it indicates the total amount of CBD contained within the container, and then you have to read the labeling to identify if I use 1 milliliter or half a milliliter, how much CBD is contained within that. Some labeling will indicate hemp oil, the total, and some others will indicate CBD total. So those are not the same. So it could contain 19 milligrams of hemp oil, for example, which would only result in 5 milligrams of CBD, but you may not see both on the labels. So it can be misleading. If it indicates hemp oil 19 milligrams, it would lend you to think that you're getting 19 milligrams of CBD, but that's not the case. You're just getting 19 milligrams of the plant part, and only a portion of that 19 milligrams contains actual CBD. And some labels avoid putting the CBD content on their label altogether and just put the total phytocannabinoid content. So as you can see with all these variations, it becomes very confusing. So when we consider doses and recommendations for patients, there's really no correct CBD dosage. There are different things that should be considered, like body type, CBD tolerance. Are they, do they have a history of marijuana use? Have they used other CBD products before? Also, like, what's the severity of their symptoms being addressed, and have they used CBD for that specific condition before? What's their overall health status? Are they looking to treat a chronic condition, or are they looking to treat more of an acute condition? And how long has the patient been afflicted? And then, you know, the recommendation will really be dependent on the product type, the concentration, and the formulation, which all will impact the bioavailability, which means it impacts how much of that CBD will actually get into circulation to provide benefit. The average CBD dose ranges between 5 and 50 milligrams. There are a lot of different kind of dosing or recommendation techniques, like start low and go slow. Start at a low dose and gradually increase until you reach the benefits that you're looking for. Others will cast a wide net. So they'll use a dosage form that's not as specific to a condition, and possibly a higher dose. And then there's a lot of non-specific dosing as well, like with creams. You know, you apply some amount of cream. Well, my pea size is different than your pea size, or your dollop is different than my dollop. So the actual dose is very hard to measure. You know, when I speak with patients, I always encourage them to document their doses, what time of day they're taking it, other factors, what they ate possibly, and how they felt before and after consuming that CBD. So that'll help to gauge, you know, recommendations moving forward if we're accomplishing the goal of using that CBD, or what adjustments can be made moving forward to gain more benefit if they're not seeing benefit at all. So again, casting a wide net is really using a product with an above average content and very little flexibility in dosing. Capsules are one of the things that pops into mind the most. So, you know, you take it, you consume it, you swallow it, then a lot of that CBD will go through first pass metabolism and then absorb throughout the bloodstream. That's very non-specific, it's non-targeted, and that can be beneficial for some patients depending on what they're looking to treat. Non-specific dosing is, similar to that, that capsule, but really more with an unspecified amount of CBD or an unmeasurable amount of CBD. And then others will make recommendations to kind of start low and go slow. So I often find that patients have the greatest success with the sublingual and liquid formulations. They have a lot of control over their dosing. It's easily adjusted. If different times of day they need more support than others, then they have the flexibility to take more. Or if they use the sublingual, then and they don't get quite the desired effects, they can redose and control how much they're redosing with. So just a note here, a lot of patients will ask about drug testing. So any product containing less than 0.3% THC could result in a positive test. So pretty much any THC product out on the market, CBD product out on the market could result in a positive drug test. CBD products are derived from the hemp plant, and this legal CBD, the legalization of CBD requires that, the THC content is less than or equal to 0.3%, which means that any OTC product, any product that claims to contain CBD could result in a positive test. So I'll get into just a couple of case studies here. These are common situations that I encounter or questions. So a 38-year-old male presents to the pharmacy or presents to you or the office, and he has an inflammatory condition, spondylitis. So he operates heavy machinery for an occupation and would like to avoid prescription medications and has considered CBD. What benefits could CBD provide? What dosage forms would be most helpful? What other considerations should be taken into account? And what suggestions can we make regarding his CBD therapy? So this particular patient could definitely get benefit from CBD itself. A couple things that come to mind: CBD does provide anti-inflammatory benefits. Because he operates heavy machinery, we want to kind of be mindful if he gets drug tested. Generally speaking, CBD products are very well tolerated, but I would certainly ask if he's on any other medications to identify whether he's currently taking any opioids or NSAIDs or other medications like blood thinners that could potentially interact with that CBD. But I would possibly consider something like a cream for this particular patient if he, is getting drug tested, or if he just doesn't, if he's concerned about the potential effects of CBD circulating throughout the bloodstream. If he has very targeted or localized inflammatory like pain, a cream may be of benefit, and he can massage that in well, and massaging it in well will increase blood flow to the area and improve penetration of the CBD product itself. Bear with me just a second. I think I addressed those questions. So another situation that's very common, a middle-aged female with chronic pain and post-traumatic stress disorder following a motor vehicle accident about 10 years ago presents with interest in using a CBD product. Her primary job function involves desk work, and she reports pain in a lot of different areas. She has constant head, neck, back pain, with leg pain and cramping in her lower back pretty regularly. She's interested in topical CBD. So this is a very typical situation where I would make the recommendation to use some type of oral sublingual product, liquid that she has very controlled dosing over. And the reason why I would steer away from something like a topical is because the pain that she's reporting is in multiple areas of her body. So she may have to douse herself in cream in order to get the full benefits, but since she also has PTSD, following that motor vehicle accident, the consumed CBD could also, circulate and have a greater impact on that ECS to regulate anxiety and her overall, mental health and well-being, and have a more controlled response in that fight or flight or stress type situation and anxiety when she has, a potential episode. So, if she's currently taking something else, of course that would be helpful to know, but I would certainly lean towards more of a sublingual where she can have controlled dosing that will provide benefits throughout all different areas of her body, but also provide possibly some pain relief, some stress and anxiety relieving benefits from the PTSD. And then we'll take a quick look at this. This patient has anxiety, fatigue, and fibromyalgia. She's retired and cares for her grandchildren. She's on other medications, but she's interested in topical CBD. This is a very common type of presentation. Again, my inclination is to recommend a sublingual with some controlled dosing to start low and gradually increase. If she's caring for her grandchildren, maybe she's concerned about, how it's going to affect her, but starting low and gradually increasing would be helpful. I would try to identify what other medications specifically she's taking so that, if she does consume, like swallow it, as opposed to let the medication absorb through the mucosal membranes in her mouth, if there will be any type of drug interactions. So
All right, so thanks for joining, everyone. We're going to be talking about some non-operative management of spine surgery, or excuse me, spine injuries. When people think of back pain, first thing that comes to mind is stories about horrible fusion operations or kind of patients who've just had a number of surgeries and not gotten any better. And surgery is not always the best option for patients. So today we're going to touch base and talk a little bit about what some of those other options are. Not only things that can take place with surgery, but things that may also be treatments before surgery or even after surgery. So my practice is 100% spine. I do take occasional trauma call, do some hip fractures here and there, but I take care of pretty much every type of spine injury, from the cervical down to the lumbar spine, sacroiliac joint surgery, as well as robotic spine surgery, which we just launched a program over at Parkland Medical Center. So I always like to start these talks with a brief overview of spine terminology. These are things that you probably see on an MRI report or hear patients talking about, or physicians or other case managers. So first thing is spondylosis, and this is just degeneration in the spine. That's what it means. It's just essentially arthritis in the spine. So nothing scary when you hear that. Spondylolysis, this is when there's a defect in the bone called the pars. This is essentially a crack. It can be a stress fracture, or it can happen with more high impact injuries like a fall or a motor vehicle accident. Stenosis just means that the spinal canal is getting narrow, or the nerve foramen. So in the cervical spine, we have a spinal cord in the canal, and we have nerve roots in the foramen. So if the canal gets compromised with stenosis, that can lead to symptoms like feeling off balance or clumsy in your hands. Whereas if the nerve tunnel gets tight, that can lead to symptoms of pain shooting into the extremities. Spondylolisthesis is when one vertebrae slips forward on the other. Spondyloptosis is when the vertebrae slips forward and then completely falls off, basically like a dislocation. Radiculopathy is an issue with the nerve roots. So again, when the nerve roots get pinched in the tunnels, it can cause radiculopathy, which is symptoms like pain, burning, numbness, or tingling, even weakness. And then myelopathy is when the spinal cord, which is present in the cervical thoracic spine, gets pinched. A couple of things I like to talk about. These are things that you see all the time on MRI reports: disc bulges, protrusions, extrusions. So I want to just take a second, talk about what the differences are. So a protrusion is when the inside part of the disc, which is the shock absorbing part, gets pushed outwards towards the spinal canal, but the thick outer ligament remains intact. So this outer ligament stays intact, it just pushes out. That's a protrusion. If this protrusion is more than 25% of the circumference, It's called a disc bulge. And a lot of patients read their MRI reports and they see disc bulges here and there and they get worked up about it. It's not something that I usually get worked up about, because if I went out on the street and found 100 people who weren't having any type of back pain, put them in an MRI, probably about 60 or 70 of them would have some sort of bulging disc on MRI. The next stage is a disc extrusion, and this is when the annulus, or that thick outer ligament, actually gets a tear, and that jelly on the inside actually can break through that ligament tear. And then finally you have a sequestration, which is an actual piece that's floating free. It's not attached by a stalk. And these are also presented from worst prognosis to best prognosis. So when you have a disc herniation, the body sees it like a foreign object, makes a new blood supply that comes in, and special inflammatory cells resorb the disc. So when a fragment is sequestered like this, the body really sees it like a foreign object, so it reliably will resorb it, versus a protrusion, because you still have this ligament that's covering everything. The body doesn't do as good of a job at resorbing it. So in the lumbar spine, we have 5 lumbar vertebrae. So one of the challenges in spine surgery is figuring out where pain comes from. So pain can come from the disc. There are pain fibers in the outer ligament that I was mentioning before, which is called the annulus fibrosus. Pain can come from the joints in the back. Those are called facet joints. We have ligaments that attach the spinous processes on the back, in between. We have joint capsules, and then we have the nerves that come out and go into the leg. So depending on what pattern of pain the patient's having helps us try to figure out exactly what treatment may be the best option for them. So again, this is another schematic showing the lumbar vertebrae connected to the sacrum, the discs in between, with the nerve roots traveling downwards. So as you get older, that squishy inner shock absorber part, it starts to dehydrate. And when it dehydrates, it starts to shrink. And as that disc shrinks in height, those facet joints in the back start to see more stress. And with more stress, things wear out and become more painful. So this is the degenerative cascade that leads to wear and tear in the lumbar spine. So this is an example of a healthy vertebrae and healthy discs. You can see the nucleus. This is actually a better close-up. So this is an example of a normal disc, and this is an example of disc degeneration. You can see how dehydrated and shrunken it is. And then on this film on the right, you can actually see what we had mentioned before, the spondylolisthesis. So if this is S1, this is L5. So you can see that L4 is sitting forward on L5, and then L3 is sitting forward on L4. So this would be a spondylolisthesis L3-4 and L4-5. So on MRI, what do these disc herniations look like? So, oops, let me go back. So on this image, fluid shows up bright white. So we like to see a lot of fluid in the discs. Remember, those discs are nice and hydrated. That's what gives them the shock absorbing compression qualities to them. And as they start to degenerate, they turn from bright to very dark and very narrowed. So this is an example of a very young patient with healthy discs, and then you can see that bright signal starts to darken, and over time it turns completely black, and then it starts to degenerate and starts to shrink in size. So each movement that we do with our trunk causes pressure on the discs. So there's always a compression side and a tension side, depending on what type of movement you're doing. And this can determine what kind of injury patients have. So if they have a fall and they flex forward, that causes a lot of compression anteriorly, tension posteriorly. Tissues tend to fail in tension. So if you have a lot of tension, you can get tears, and that can lead to disc herniations. So I'm going to start talking a little bit about ways to treat pain other than surgery. And one thing I want to touch on is CBT, or cognitive behavioral therapy. Something that I've recently started sending more patients to, because I've noticed a lot of spine patients who have anxiety surrounding their conditions, anxiety surrounding their pain. They tend to pain catastrophize, which is when they start to get fearful of becoming painful, which leads them to have pain in the first place. And it's this very vicious cycle. This is kind of a diagram showing the three components that lead to chronic pain, which are thoughts, which lead to emotions, which lead to behaviors. And all these things influence each other. This is wrapped up, I think, a little bit more nicely and succinctly, but behavior reinforces thoughts. These thoughts are what create our feelings. Feelings create behavior. So patients are doing something and they say, hey, last time I did this, my back started hurting. They start to get anxious about doing that, and then they start to avoid doing it. And as you start to avoid doing activities, the muscles become weaker, which leads to more injuries, and it becomes a vicious cycle. So cognitive behavioral therapy is a type of therapy, and there's a number of different ways that you can go about this. In 2021, we have a lot of apps. There are a number of apps that teach either mindfulness or put you in touch with a counselor where you can actually text or you can talk with to get help. Some places are opening up in-office interviews and in-office therapy programs, or even something as simple as having your patient's journal can be helpful. Write down the things they noticed that were causing them pain and how that made them feel, and they can start to see patterns and try to work through things themselves. There's a study, I'm going to try to keep this as clinical as possible, but we'll throw in some studies here and there. This was a study in JAMA in 2016. This compared patients to either have mindfulness-based stress reduction, which is essentially mindful meditation, versus cognitive behavioral therapy, or usual care. And usual care was what you think about, so physical therapy, anti-inflammatories. And patients with chronic back pain, there was a much bigger difference, 44 and 45% versus 27%. So almost half of patients reported back pain improved versus only a third of patients in the usual care group. So there is definitely a role for this in back pain and back pain injuries. So talking a little bit about back pain, it's one of the most common reasons to come to a doctor in the United States. About 80% of patients, or 80% of Americans, will have low back pain at some point in their life. And this is a very, very expensive issue that affects our healthcare system. So I've been seeing this a lot in clinic, is patients coming in with pain and they want an immediate fix and they want opiates. And I try to avoid prescribing opiates as much as possible because there is a lot of misuse. It's kind of a slippery slope. Once you start prescribing opiates, it starts leading to more and more refills, and it's something I like to try to avoid. So that's one of the reasons why I'm presenting this, just to put out different strategies for treating these chronic pain patients. Skip the slide. So the first thing I do is take a history, and I want to know where the pain is, how long it's been present for, what sort of symptoms. Basically what I'm trying to do is I'm trying to figure out, is there something emergent that we need to look at closer? Is there something urgent? Is this something that needs surgery, or is this something that can be managed without surgery? And the history is where we start. The physical exam comes next, and then we back this up with imaging, and we try to correlate all these things together. So when a patient tells me a story and I examine them and it makes sense with the story, and then I look at their x-rays or their MRI and all these things match up, those are patients who usually do very well with surgery. Patients who come in, they have very vague stories, or they've been in pain for 15 years and it changes, it's here, it's there, it's burning. When things aren't as kind of concise and patients are all over the place, and then you examine them and what they're telling you doesn't really match up, and it doesn't match up with the MRI, those are patients I definitely steer away from surgery, because they're not going to do well with surgery, and they would much benefit, or they would benefit much greater from something like cognitive behavioral therapy or one of the other treatments that we'll be talking about. So one thing we'll talk about is spinal cord stimulation. So spinal cord stimulation is a little bit newer. I'm not sure exactly how long it's been out for, but the technology available now is pretty impressive. And I'll show you some examples of this in a little bit. But spinal cord stimulation essentially is a paddle with electrodes on it that gets implanted on the inside the spinal canal on the posterior aspect of the spinal cord. And this paddle is hooked up to a battery which sends impulses to the electrodes, which stimulates the posterior part of the spinal cord. And that's the part of the spinal cord that has all the sensation fibers in it. So initially, the spinal cord stimulators would basically take the pain signals and transform them and make patients feel like they were having tingling sensations. They're essentially, what the electrodes are doing is interrupting that pain signal from traveling up the spinal cord to the brain. And if you have the right candidate for this, patients do very well. I had one lady who, she came to my office a few days after having a spinal cord stimulator. She was actually crying because it was the first time she had been able to sleep through the night in like 10 or 15 years. So it definitely does make a big difference in the right patient. It can be used for a number of different types of pains. And the nice thing is that these are all things that we really don't want to have to operate on again, right? So people who have failed back syndrome, that means they've already had a back operation that hasn't worked. Again, failed back syndrome, multiple back operations, unsuccessful disc surgery. So all these things are essentially, doing another operation on these patients is really not the best idea. Or if someone's had kind of chronic pain from degenerated discs that we just have not been able to get under control with conservative measures. So this is an example of what this looks like. So the electrode goes in the spinal canal. You can see a schematic of this on the left. This is what it looks like on X-ray. And then there are wires that are tunneled down through the skin. And then this is the battery. So it's an implantable pulse generator, or IPG. And this is what's responsible for sending the signals up to the electrodes to disrupt that pain pathway. So these paddles are placed through a very small laminotomy window. This is usually done in an outpatient setting. The implantation usually takes about an hour to an hour and a half or so. And patients usually go home the same day. So there is a surgical aspect to it, but this is a lot less invasive than like a lumbar fusion or a big decompression. This is an example of what the batteries look like. So there are two different types of batteries. There are ones that are rechargeable. So just like most wireless phones now, or wireless cell phones, I guess they're all wireless, but cell phones can be charged wirelessly. So the same idea with these batteries is basically you just hook up the charger, or you place it on the skin right by the battery and it charges up. Or ones that are slightly bigger aren't rechargeable, but they last longer. These are very expensive. These are like this, the cost of a small car. This is a sawbone showing how small the window is made in the bone, and then the electrodes are placed into the spinal canal, and this is an example of the wires coming down. This is one more X-ray of what the electrodes look like. So how is this actually done? So once I determine that a patient's a candidate for this, they undergo a spinal cord stimulator trial. And the trial lasts for 7 days to 10 days, somewhere in there. And this is done in a office setting usually. So just like getting a epidural steroid injection, it's usually done with a small needle. The wires are fished through the needle into the epidural space and placed just on the outside of the spinal cord. And then the impulse generator, instead of being implantable, is actually worn on a belt for the first 7 to 10 days. And what I always tell patients about this is it's neat because this is essentially the only surgery that you can take for a test drive before you have it done. So you can actually get a pretty good idea of what's going to happen after surgery before you even have it done. So it's pretty unique in that regard. If a patient has over 50% pain relief from the trial, then they're a good candidate for having the permanent electrode placed. This is an example of what the technology looks like now. So again, now everything is wireless, hooked up to apps and tablets and phones. This is an example of the wireless recharger that you can just place right over the skin. So moving on, I'm going to talk a little bit about photobiomodulation. So another word for this is cold laser treatment. One company is Ortho Laser. And I know there's one down in Chelmsford. I think there's one that's opening up soon in Nashua. But I want to talk a little bit about what this is like. So the idea of cold laser treatment is laser is light, light is a form of energy, and when energy interacts with tissues, we get an effect from that. And with the right wavelengths, that can be a positive effect, or with the wrong wavelengths, it can be a negative effect. So this cold laser treatment has pain reducing properties, as an anti-inflammatory property, and it also stimulates healing. So on the cellular level, it increases RNA, and RNA is needed for protein synthesis, which is ongoing with regeneration and healing. Again, it's anti-inflammatory, it's analgesic. It decreases edema because it increases vasodilation and increases nutrients and oxygen to the tissues to stimulate healing. Again, those are all the things I just had mentioned. It can be very beneficial for what we're talking about today, which is neck and back injuries, but also other types of tendinitis, osteoarthritis is all very commonly treated with cold laser treatment. And this is usually done over, I believe the treatment lasts something like 5 to 10 minutes, and it's usually done over 5 sessions. So as a surgeon, I always think about things risk benefits. The risk of having someone do cold laser therapy is, basically zero. The only risk is the risk to their wallet or how much it costs them. And there's a potential huge benefit. And when I was first doing research for this talk, I found this. I was like, I don't know. It sounds a little fishy. So I did a literature search, and there was a number of double-blind placebo-controlled studies looking at all sorts of different conditions. So everything from neuropathic pain, surgery recovery, osteoarthritis, sprained strains, fractures. So it's pretty impressive, and the results that I found were pretty promising. So if this one does open up in Nashua, then I'm going to be one of the first customers because I want to try it out on myself. We're going to talk a little bit about spinal stenosis because the remaining, or a couple more of the treatments that we're going to be talking about have specifically indications for spinal stenosis. So patients who have spinal stenosis have narrowing of the spinal canal. And what I tell patients in the office is normally in our lumbar spine, we have nerve roots. And if you look at the nerve roots in the operating room at this area, it looks like spaghetti floating in water. The nerves are in their spinal fluid. They're just floating nice and free. And with spinal stenosis, those nerves get pinched and they get bunched up. And those nerves are the nerves that go into our legs. And when that happens, it can cause pain. So the typical patient with spinal stenosis is someone who, whenever they stand and they walk, they start to get cramping pain in their buttocks, the back of their legs. And when they sit or when they lean forward, the pain goes away. And the reason that it happens is because when you stand and when you walk, your back goes into extension. And when your back extends, the ligament folds inward and can pinch the nerves. When you flex, the ligament gets tight and causes that space to open up. So one thing patients will commonly say is, you know, if I stand and I try to walk to the mailbox, you know, I have to stop, you know, 2 or 3 times. But if I go grocery shopping, I can walk a lot longer if I'm leaning on the cart. And that's because when they're leaning on the cart, their spine flexes forward and their spinal canal is more open. One treatment that is a lot less invasive than spinal surgery is what's called an interspinous spacer. And these get inserted between the spinous processes, and these prevent the extension movement of the lumbar spine. These are done through an extremely small incision. It's a same-day procedure. They're usually done in an office or a surgical center setting. It takes about 30 minutes. So like we talked about, during extension, the spinal canal and the neuroforamen get smaller. So if you put something that blocks the extension or even opens it up the other way, that can relieve pain. So this is an example of what the interspinous spacer looks like. This is called the superion. And this is what it looks like when it gets implanted. So you can see how small that incision is. And this implant goes in between the 2 spinous processes. And then it's deployed. And these 2 wings attach to the spinous process. And they open that space up and they prevent the extension. So this is very good for people who have back and leg pain that gets better when they sit or when they lean forward. This is something that I would definitely recommend for patients, you know, as they're getting older. I've had a few patients who, you know, they're still active, but they were in their 90s or they had medical comorbidities, and I didn't feel like they'd be a good surgical candidate. So I had them referred for superion, and patients usually do very well with this procedure. This is an example of what it looks like on X-ray. So you can see it wraps around the spinous process and it goes in between to prevent that extension. You can see the rate of patient satisfaction from, you know, the mid 80s at 2 years all the way to 90% at 5 years. Improvements in physical function as well as symptom severity. And the patients who I typically refer for these procedures are those patients who have leg pain with or without back pain that gets better with forward flexion. That's a big component of this. Is if they don't get better with it leaning forward, then chances are this operation isn't going to help them. And one of the ways you can ensure that you have a successful procedure or a good outcome is to make sure you're selecting the right patients. So if there's a patient who has a fracture, if there's a fusion, if there's infection, or if there's instability, these are patients who usually are not good candidates for this. And the whole idea is you're relying on that force between the 2 spinous processes to open that space up. So if they're fused, it's not going to move. If there's a fracture, you're not going to have anything to push against. If there's an infection, the bone's going to be soft, and things are unstable, it's going to cause shifting. There are other types of interspinous spacers that get put in during minimally invasive spinal surgery. So these are typically more severe, so moderate to severe stenosis patients, or if they have a spondylolisthesis up to a grade 1, where there's going to be some instability. I just heard a weird ding on my... I'm going to keep going. So we'll talk about radiofrequency ablations next. Okay, I'm just going to minimize my screen. Sorry about that. So in our spine, we have facet joints, and these are the joints that let us bend forwards and backwards and side to side. So these joints have nerves called the medial branch of the nerve. And the only responsibility of this nerve is to send pain signals from the joint down the nerve into the spine and up to the brain. So radiofrequency ablation is using radiofrequency to burn or cauterize these little nerve endings to prevent that pain signal from getting to the brain. This, the first part of this is having what's called a medial branch block, and this is when a local anesthetic like lidocaine or marcaine gets injected around the medial branch of the nerve to determine whether or not this is where the pain is coming from. So most insurance companies require that this is done before radiofrequency ablation in order to prove and diagnose and confirm which level needs to be targeted. We also do injections. So injections can be done into the facet joint. So just like people get cortisone shots in their knees, hips, or shoulders, we do the same thing into the spine, and that can be done either into the facet joint or into the sacroiliac joint or the hip. All these things can be injured in back patients. Radiofrequency ablation also can be done for the sacroiliac joint. These typically provide about 75% pain relief versus radiofrequency ablations for facet disease with 60% relief. But the idea is that the sacroiliac joint, which would be on the outside here, receives nerve contributions from all of the branches of the sacral nerves. So radiofrequency ablation of the sacroiliac joint is a little bit more involved because you have to walk up the entire length of the joint in order to ensure that you lesion or cauterize all the little nerve endings. Let's talk about dry needling. So a lot of patients who get injured have some underlying arthritis or degeneration or spondylosis. Remember, that all means the same thing. And patients who have an underlying condition that gets exacerbated by an injury typically get a lot of inflammation. And the body's natural response to inflammation is to try to splint it. And the way the body splints itself is by making muscles tight and spasm. And that can lead to what's called, or what are called, trigger points. This is an example of dry needling, which can be done for trigger points. You can also have trigger point injections. And the idea behind this is a trigger point is a knot, essentially. And what happens is you get into this vicious cycle of shortening, which leads to a hypercontractive band. And you can see this cycle with increased calcium release causes these very tight bands to develop. And these can be extremely painful, and they can be very, very sharp. So trigger point injections or dry needling is when you take a needle and you insert it into one of those tight bands or one of those trigger points, and it releases cytokines or growth factors or neurotransmitters that get those tight bands to release. And this was something that I hadn't heard much about during my training. When I started New Hampshire Orthopedic Center, I took over for Dr. Price, and he'd been a big proponent of dry needling. So for my own education, whenever I sent a patient for physical therapy and I had them come back, if they were getting better, I'd always ask, what helped you the most? And patients who had muscular pain or arthritic conditions leading to muscular pain almost always said that the dry needling was very effective for them. The last thing I'm just going to mention briefly are epidural steroid injections. There are two types of injections. There's interlaminar, which is depicted up here on the top, and there's transforaminal injections. So the way I think about interlaminar injections are they're more generalized. They go into the epidural space and they kind of travel up and down, versus a transforaminal injection is targeting usually a specific nerve root. So I use transforaminal injections more for diagnostic purposes. If I want to numb up a nerve to prove that the pain's coming from that location, versus an interlaminar injection, which I may use if there are multiple areas that need medication injected into. So I'm gonna stop there. I think I got about 10 minutes left, so we can open up for questions if anyone has any.
If Could you give us an idea of what percentage of patients actually go through with an implant of a spinal cord stimulator?
I think that really depends on patient selection. So if you're selecting patients who have had multiple surgeries and they've done physical therapy and medications and they've been on opiates and they've tried the chiropractor, they've tried everything under the sun. I think if you're sending those patients over, if they find any relief at all, those patients are usually happy and they almost always go through with the spinal cord stimulator placement. Younger people tend to be more on the fence. They're more leery about having something implanted permanently. But I definitely think older patients or people who've been dealing with more chronic issues typically undergo the spinal cord implantation.
Do you see that there's any pain behavior in those patients post-implantation?
So there is still pain. It's not blocking all the pain receptors, but it's kind of like the same idea of using icy hot on an area that's injured, right? The icy hot isn't killing the pain. The pain's there. It's just tricking your body to focus on something else. So icy hot or Bengay, it's focusing on that burning sensation. So it's the same idea with the spinal cord stimulator. It translates more into like a tingling type feeling. And the spinal cord stimulators have basically not a volume level, but you can control the level of intensity to get more or less pain relief depending on what symptoms are resolved by the implantation.
The laser therapy you discussed, you mentioned how many sessions. Is this a permanent or is it a temporary relief?
It can be a permanent. So if there's an issue with, so it depends on what the issue is. So with things like tendinitis, if those are from overuse or sports injuries, it can be permanent until someone goes out and either re-injures or continues to use that tendon. It can be very helpful for healing also, but it's not as permanent with things that are end stage like arthritis. Mm-hmm. It's not something that I've ever had done. I haven't had any patients report back to me yet, so it's still something very new. But it's something I'm definitely going to be investigating in the future.
Okay. In your research, was there any downtime post procedure?
For the laser therapy?
Yes.
No, it's painless. Some people say it feels like a warming sensation, but it's no downtime at all. It's 5 to 10 minutes, I believe, and there's no incisions. There's no risk associated with it.
How do you distinguish pain in an SI joint versus a lumbar?
Sorry about that. So I start with history. So everything always starts with history. So talking with the patient is the number one thing. So patients with sacroiliac joint issues typically have pain for prolonged sitting. So if they're sitting for a long time, they kind of shimmy back and forth. They can't get comfortable. They're always kind of leaning and propping themselves up. Transitions are very painful for them. So getting into or out of something low, like a car or off of a toilet, those things can be very painful. The second thing is physical exam. So focusing on maneuvers that stress the sacroiliac joint. So if someone has lumbar stenosis, even though arthritis in the spine, stenosis, and sacroiliac, they can all cause the same symptoms. If someone has lumbar issues, if I stress their sacroiliac joint, it's not going to cause them pain. So the first thing is the history. That lets me start kind of making a differential diagnosis in my head. And then I move forward, I examine them. I start to rule things in or rule things out. And then we do imaging. So again, if I see arthritis on the sacroiliac joints, that kind of clues me in. And then we can do a diagnostic injection, which is injecting lidocaine. So if you inject lidocaine into a joint and the pain goes away completely, even if it's only temporarily, we at least know that the pain's coming from that location.
When you discuss the spacers, about how long does that last, and does it prevent having to have a fusion at a later date?
Yeah, so they're permanent. So they're put in and they're not really they can be taken out, but they're not, there's no like specific time where people come back in to get them out. So it's a permanent placement, and it can prevent the need from needing a fusion. So people always come in, they're always asking, you know, how bad does my MRI look? Do I need surgery? And I always tell them, I'm not operating on an MRI, I'm not operating on x-rays, I'm operating on you, and I only will operate on you if you're having symptoms. So I wouldn't operate on someone who's not having any symptoms. And some patients get these interspinous spacers and all their pain goes away. So that may completely, you know, obviate the need for a fusion in the future. Some patients are going to continue to have progression, things may worsen. In that case, the spacer doesn't really burn any bridges. We could still do a fusion if we needed to.
I think those are the questions that have come our way. If there's any more, just type them into the chat box. Otherwise, I thank you very much, Dr. Klare, and for your time and your expertise.
Thank you. I appreciate you guys.
Welcome. All right, thank you.